70% of them don't have accurate ingredient lists. Shouldn't that worry people about the supplement industry?
Uh-oh.
And I think they should be cautious, careful.
How does he just walk back on every fight with no pushback at all? How does he just walk back on everything?
That and recommend certain brands for my patients.
Oh, okay.
And if,
So trust your doctor? Is that what he just said?
they settled on our question about the compliance issue.
Uh-oh.
That you mentioned that getting these imaging tests is valuable.
This guy is getting the most gentle questioning of all time. It is so gentle. And this guy's like fucking pressed as fuck. He's so pressed right now. Holy shit.
NFL players, high levels of damage, but 80% of our players got better. We put them on a really good multiple vitamin, high dose, high quality fish oil, and a supplement, brain supplement that works in 6 different ways.
Oh! It's the fish oil capsules for my fucked up brain from getting smashed in the head 4 million fucking times by dudes that are 6'4", 300 pounds. I need the omega-3 fatty acids.
Don't you want to try and disprove your method in order to prove how strong it is?
So at this point in my career, no.
I know.
A SPECT scan takes 3D images of the brain, looking at blood flow and activity. Dr. Amen says the images can be a powerful tool to diagnose underlying problems.
I have more experience in this than anybody probably in the history of the world.
Do you not feel that it's an issue that there is no randomized control data?
You know, I went and got a brain scan by this guy called Daniel Amen.
How do you know?
Is that the guy?
What is actually going on in that person's brain without looking?
By asking them questions, by doing some
That's
validated
complete crap, Mike. It's complete crap.
Today's guest is Dr. Daniel Amen, a physician with double board certifications in psychiatry and child and adolescent psychiatry. He's a multiple New York Times bestselling author and has just published a new book called Change Your Brain, Change Your Pain. He is also the founder of Amen Clinics, a nationwide network of offices that rely heavily on SPECT scans, a unique functional imaging approach that Dr. Amen claims is capable of identifying psychiatric diagnoses within the brain, which allows them to create.
Do we like Dr. Mike? I think we all like Dr. Mike. Dr. Mike is like the Dr. K of Dr. Mike. I don't know what that's supposed to mean because technically Dr. K is a doctor as well, so he's a good guy, I think.
Better treatment plans for his patients, which often include supplements he sells through his other company, BrainMD. As you'll hear him say, he's reviewed hundreds of thousands of these scans, which he's used to improve the lives of countless patients over his decades-long career. Given that major health organizations have come out against using SPECT in this way, I needed to ask what research he was using to guide his protocols. Because if you're gonna go against the APA, the AAN, you have to have some pretty compelling data, right? Let's talk historically how you got into this space, because I don't see a lot of folks, at least on the internet, talking about neurology, psychiatry, and how these two fields come together. Is this a unique field? I'm not certainly exposed to it as a primary care doctor, so I'm curious how you found your interest in that.
So when I was 18, Vietnam was going on, and I became an infantry medic, and that's where my love of medicine was born. But about a year into it, I realized I didn't like being shot at, so I got retrained as an X-ray technician. And that was pivotal for me because our professors used to say, how do you know unless you look? And then 1979, I'm a second-year medical student. Someone I love tries to kill herself, and I took her to see a wonderful psychiatrist. And I came to realize if he helped her, which he did, it wouldn't just help her, that it would help me. It would help her children. It would help her grandchildren, as they would be shaped by someone who was happier and more stable. So 46 years ago, I fell in love with psychiatry. I've loved it every day since. The only medical specialty that never looks at the organ it treats. Think about it.
Contrary to a popular myth, psychiatrists routinely look at the brain for some aspects of patient care. For instance, PET is increasingly used for dementia assessment, and MRI is recommended for some patients with new onset psychosis.
That.
Is that true?
That is absolutely true, that they still make diagnoses based on symptom clusters, the DSM, that has no neuroscience in it. They make diagnoses based on symptom clusters with no biological data, exactly like they did with Abraham Lincoln in 1841. So think about that.
Yeah,
right?
Warning, you don't always have to like look at an organ to do a differential or to figure out like what might be wrong with a person. Like self-reporting is pretty important. In fact, I'm going to pull this number out of my ass, but it wouldn't surprise me if like 80% or 90% of all doctor visits or whatever prescriptions might be done without doing like an MRI or a PET scan or some other like sophisticated imaging technology, depending on if you're just getting like a routine prescription for a thing. I mean, it depends obviously on what you're talking about, but.
Is that?
Because it's the paradigm that feeds the pharmaceutical industry. It doesn't feed outcomes because our outcomes are not better than they were in the 1950s, the year I was born.
How are you? Where is
be,
the, like in terms of more people being sick or people not being helped?
More people being sick. And if you are sick, your ability to get better, right? Imipramine was released in the 1950s. We don't have antidepressants that are more effective. Now, we have ones with fewer side effects, but not more efficacy. Thorazine was released in the 1950s. Ritalin was released in the 1950s. Why? And so I asked the question, and when I was growing up, my dad had two favorite phrases. Bullshit was his first one. Everything was bullshit. And no, bullshit, no. And so when I'm like, well, why aren't we looking? They go, well, it's the future. And I'm like, bullshit, no, we should do it now. There's technology now. And in 1991, I went to a lecture on the imaging study we do at Amen Clinics. I have 11 clinics around the country. It's called Brain SPECT imaging. SPECT is a nuclear medicine study that looks at blood flow and activity. It looks at how your brain works. And
how's that different from functional MRI?
So functional MRI is harder. You have to catch that difference in brain activity. SPECT actually gives you a look at how the brain works over time. So it looks at about a 2-minute snapshot of brain activity, but it happens to be very consistent over your lifetime, unless you do things to change your brain. And so now we have almost 300,000 scans we've done on people from 155 countries. And literally, it changed everything in my life from the time I go to bed, because what I realize, most psychiatric illnesses are not mental health issues, they're brain health issues. Get your brain healthy and your mind will follow. And so when you...
How is that? What's the difference between mental versus
So if you
brain?
think of it as mental health, so number one, no one wants to be called mental, right? Because it shames you, it's stigmatizing, and it's sort of about you. When it's brain health, well, everybody wants it. And if it's mental health, okay, diagnoses, symptom clusters, let's do this medicine or that medicine, right? As a family doctor, you treat more psychiatric patients than most psychiatrists. It's like almost half of the patients that come see you are stressed, they're not sleeping, they're anxious or depressed.
Especially my pain patients.
And the tools you have in a limited office visit is medicine. And yeah, it's like, okay, symptom clusters, medicine or therapy, and then I'll see you back. Where if it's brain health, you have to lose weight. Because I published 3 studies on 33,000 people that show as your weight goes up, the size and function of your brain goes down, which should scare the fat off anyone. You have to get your diabetes under control. You need to go to bed. Alcohol is not a health food, and marijuana is not innocuous. So what you begin every patient, this is not true if it's sort of a mental health issue. If it's a brain health issue, you have to ask yourself, whatever you're doing today, is it good or bad for your brain? So it's a completely...
Sometimes I wish, again, and I stress this a lot, and it's unfortunate that I don't know if it's because Big Pharma has captured all these guys. I wish doctors would recognize more that, like, if you diet and exercise well, that it's probably good for other parts of your body too. It's really annoying that, you know, every time you go to the doctor, you've got all these issues and you're like, doctor, like, I'm thinking about starting, you know, diet and exercise or whatever. And the doctor's like, no, that won't make any difference. I've got a new Pfizer drug for you. Trust me, okay? Don't diet. Don't exercise. Don't sleep ever. In fact, smoke as much weed as you can. Do a fucking 3 glasses of wine a day and do all this shit and you'll just be fine. Trust me, right? I wish the doctors were more honest about the fact that diet, exercise, and sleep can have major impacts on your health. But I'm so glad we have alternative medicine specialists like this guy to remind us what Big Pharma and Big Doc are hiding from us.
Different paradigm and a completely different...
Like, I don't know what he just said there. I don't know if I've ever in my life heard a doctor brave enough to actually come out and say, marijuana, probably not the best thing for your health. Probably not innocuous. Probably not the best thing for your health. Does any doctor have the audacity, have the guts, the gall, the stones to make such brave statements? I don't know. I've never heard one say that before.
I'm trying to think of how I go about seeing a patient that perhaps has a psychiatric concern or maybe even doesn't realize that they have a psychiatric situation going on. Obviously doing the symptom clusters, the checklists, the PHQ-9s, all of these GAD-7s that they fill out. And then you're right, it's either therapy or medication, a combination of medication, and then see you later, especially with our broken healthcare system. It's near impossible for anyone with not the greatest insurance or paying cash to even get therapy, let alone quality therapy. So I see that happening. But the idea of weight loss and getting their diabetes under control, to me as a family medicine doctor, especially as a DO who thinks very holistically, that is almost always included in my mental health portfolio. Is it just because I'm automatically thinking about mental health as brain health?
No, it's because you're rare. Very few family doctors tell
you should lose some weight.
You're depressed. Could be from the inflammation you're creating from the extra weight.
So he takes it a step further. So he has this, sometimes you'll hear, God, they're medical buzzword bullshit words or whatever. Inflammation is one of them. Not that inflammation isn't real, but like following somebody mentioning inflammation is always going to be something about like all dairy, all sugar creates inflammation in the body, and the inflammation can adversely affect the organs in your body or your brain, and it can destroy your hormones, blah, blah. It's always going to be some bullshit like this. But it's like, this is like 100% causative. This is 100% the problem. Other quackery can follow, but...
And the ultra-processed food. It's, you're depressed, that means you need an SSRI. And, you know, the serotonin hypothesis for depression...
Bullshit.
It's not well supported.
Oh, for sure.
And
we've gone back and forth on, is it receptor modulation?
But see, I don't think depression should be an illness. I think depression is like chest pain. Nobody gets a diagnosis of chest pain. Why?
That's in my ICD-10 diagnosis.
Well, yes, but nobody gets, no thoughtful cardiologist goes, that's your problem. You have chest pain. It's a symptom.
Oh my God. Don't mind if I do.
It's a symptom that has many different causes. And there's certain brain patterns that respond to SSRIs, especially if you have increased activity in an area of the brain called the subgenual cingulate gyrus. So yes, SSRIs work for that. But what if you have low activity in that part of the brain? SSRIs can make you violent or suicidal. And there are black box warnings on SSRIs. There are black box warnings on every psychiatric drug because depression can happen from a head injury, like you had a whiplash injury, so you never even really thought you had a head injury. It could come from toxic exposure, like lead or heavy metal or mold. It could come because your brain works too hard, from Lyme disease, or not hard enough.
Got the chronic Lyme disease in here too. Oh, we're hitting all of our checkpoints.
The standard, your PHQ-9 is elevated. So here's an antidepressant plus therapy, or one or the other. And I'm like, well, why are you depressed? And that's not the question people really ask.
I'm curious about the chicken or the egg scenario with the weight and poor diet. I have patients that I believe that there's a component of their weight, their diet, their choices in life are impacting their feelings, leading to the symptom of depression. Because technically, I don't diagnose someone with depression. I diagnose them with major depressive disorder or dysthymia, some kind of more DSM appropriate diagnosis. So how do I know, is this a symptom or a sign of them having major depressive disorder leading to unhealthy eating? Or is it the other way around, that the unhealthy eating is causing those symptoms?
Well, I would think we should look at their brain before we go about changing it. And then I think a really good detailed history will give you a good idea. Now, if you can't get a scan, look at their ACE score. And I don't know if you do that
Adverse
routinely.
experiences.
But I published a study last year on 7,500 patients looking at adverse childhood experiences. So on a scale of 0 to 10, how many bad things happened to you as a child? And so if you have increased trauma, you have increased activity in your limbic or emotional brain, or when we talk about the pain book, in the suffering pathway of the brain. So you're more likely to eat simple carbohydrate foods because that raises serotonin.
Oh, yeah.
If you can get an insulin response, then it raises tryptophan in the brain and serotonin, and you feel happy. Now, you don't feel happy really. You feel happy
temporary.
You feel happy for the
until
moment.
the next
right. I want my patients to feel good now and later versus now, but
without the
later.
negative effects of overeating.
Without the negative effects.
So in these scenarios, when let's say they have elevated ACE scores and as a result they're having worse lifestyle changes, how does getting the imaging improve that level of treatment? Because let's say I have a patient who has a high ACE score, who's consuming a lot of foods. We would be discussing the consumption of those foods as part of their metabolic workup, knowing that there's an added benefit to their mental health state, but it would be primarily focused from a metabolic standpoint. So what does the imaging add to it?
So many different things. The first thing it adds is compliance, because people see their brain, they begin to have a relationship with their brain, and they want it to be better.
Okay.
So it's the reason
It's showing them a bad EKG when they're having chest pain.
or high liver function tests,
Right.
and they're drinking
For
too
fatty
much,
liver, sure.
right? In 66% of the time, if you show them an abnormal lab test, they want to do something to make it better. But now, so when I did my first scan, it was 1991, I scanned my mom the week before, and her brain was beautiful, and mine wasn't. And I developed a concept I call brain envy. Freud was wrong. Penis envy is not the cause of anybody's problem. Brain envy, right? That's the organ where size really does matter. You want a healthier brain. And I just wanted my brain to be better. So that leads to a cascades of decisions. If you go, is this good for my brain or bad for it? So that's the first thing that I fell in love with imaging, compliance, and it decreases stigma. And it gives you as a physician targets to go after. Is the brain overactive? So I need to calm it down. And from a medicine standpoint, SSRIs or anticonvulsant medications calm it down. But if it's low in activity to start and you calm it down, you've just disinhibited that person, which can be
Well, there's some activating antidepressants. Wellbutrin is a common option.
But how would you know where to start?
Well, based on symptoms and what they're
Based on
experiencing.
symptoms. But what other specialty in medicine acts without imaging?
I don't know if that's a valuable question.
But this just like all of them, right? Like, I mean, like you can, I mean, if you're a surgeon or something, I imagine you're probably doing imaging for that type of stuff. There's going to be some things where you're always doing imaging, to be fair. It depends on how broad you want to make it. But like most doctors, if you go to the hospital for a fucking, would you consider would you consider taking your temperature, like a thermometer? Would that be imaging? I wonder if you would count that as imaging. I'm like, you patient reported stuff and like just easily observable things. You don't have to scan for every single possible fucking thing you have, you know? I don't know.
because not every specialty is going to have equivalent need for imaging. For example, for me to make a diagnosis of a UTI, I don't need any imaging or any lab tests.
Lab tests.
You don't. It's a clinical diagnosis. So if someone has symptoms, dysuria,
even for STDs, I don't think I know you don't need. You don't have to do imaging to like prescribe drugs for them. Like if you describe accurate symptoms, you have a sexual history, they'll just give you a shot or they'll give you medication, and that's it.
Quick pain on a physical exam, perhaps CVA tenderness. I can make that diagnosis. I technically don't need the tests. There are moments where it's valuable to get a test if you're concerned about a kidney stone, if you're worried about someone who has a high risk UTI, like someone in pregnancy, so you need to get a urine culture to confirm sensitivity. So there's a lot of these specifics, but I'm interested in your reasoning, the compliance, the stigma. I think those are really
the roadmap.
And the roadmap of treating to some outcome. So now I'm curious about the compliance portion of that. Not every patient's going to have access to imaging, just simply because of the nature of our healthcare system. It sucks.
Also, probably not every doctor too, although I'm sure they'll get into this. I mean, maybe if you're in a super bougie hospital, but I feel like a doctor would probably get in trouble if every single time he saw a patient, he was getting like a full fucking workup. You know, I feel like this guy would be on the lab sheets constantly, and administrators or whatever be like, bro, what the fuck are you doing? How do you have 37 x-rays from, the past week of whatever? Like, I don't think you could schedule it. You don't have the machines for it. You don't have the lab techs for it. You don't have the space, the time, the scheduling. But I'm sure he's got a new special ultra amazing machine or something that he's trying to sell or some bullshit. I don't know.
A lot of people can't afford even basic medications. The other day, I prescribed clindamycin for a patient, and their insurance denied it because I sent capsules and not tablets. Just some ridiculous notion, which is typical for our system. So when I think about our system and who I treat, especially in a community health center, I think about those people who can't get imaging, and then the worry that it instills in them as if I'm treating them badly because they will view our podcast or they'll hear a news story about the need for imaging and that we're functioning basically as we're blind. And then those people feel like they can't get care from me or their psychiatrist. Do you worry about that outcome?
So from the beginning of the time, I've done imaging. And that's why I write. That's why online you can take our brain health assessment, know what, based on our work, what type of brain you have. You have a balanced brain, spontaneous brain, that's my ADD group, a persistent brain, my OCD group, sensitive or cautious brain. So these symptoms tend to go with these patterns. So I think people can benefit from my work for free, right? They go to the library and get Change Your Brain, Change Your Pain, or Change Your Brain, Change Your Life, or any of the 40 books I've written, or they can listen to our podcast. And so there's so many people, everywhere I go, people go, your work changed my life, and they never got a scan.
So the scan isn't necessary.
Like, I guess, if I was a doctor, because this guy's trained, right? He's a physician, he's got his MD. If I was a doctor, and I felt like I had stumbled upon some revolutionary way to treat mental health in a way that could actually revolutionize the mental health field, I would want to study on that. I would want to be like the guy who has the paper that everybody starts working off of. Why would you be content to sell like a pop psych or pop psychiatry book or whatever? Why not like do a study? You could like change the entire industry. You would be like the guy.
But I would argue psychiatry is broken, and we need to be viewed as a real medical specialty with imaging, because if you don't look, you don't know. So, for example, one of the big lessons is mild.
This sounds like an argument that I've heard. I feel like I heard my grandma have this once, that patients will have sometimes with doctors where it's like, how can you know if I have this if you haven't done the imaging? If you haven't scanned me, if you haven't done this or whatever. And it's like, a scan might show a million different fucking things that, depending on who you are as a patient, might not even be relevant. I think sometimes people have this idea that like everybody's blood work, everybody's organs, everything looks the exact same between all healthy people, and any deviation is something that's unhealthy. But like on imaging, you might get an error on the test, a false positive, a fucking speck on a machine or some stupid shit. There just might be something in somebody's body that just looks a little bit fucking weird. It just looks kind of strange or whatever, but it's not necessarily indicative of a problem. There might be something that looks normal for one person, but it's actually abnormal for them because you don't have like a history of scans or whatever on this person. The idea that, I don't know, this just seems like a very like, I don't want to say retard. This guy's obviously more doctory. He's a doctor, right? But like the idea, like, I need a scan. I can't know anything. I need a scan, doc. You got to scan me. I got to get scanned. I need the fucking scan. How do you know if you haven't scanned me? Scan me. Put me in the machine.
Is a major
scan me.
Of psychiatric problems, and nobody knows it because psychiatrists don't look. You don't know. So, for example, one of the big lessons is mild traumatic brain injury is a major cause of psychiatric problems, and nobody knows it because.
Like, I've heard this tons of times, that brain injuries can lead to lots of other issues related to depression, whatever, that concussions over time can lead to, or a single bad one could lead to depression or sleep issues or anxiety or whatever. Like, I've heard this before. I know this. maybe I just have access to the forbidden knowledge, but I'm pretty sure everybody knows this, especially who has like training in it. Like, well, I don't know what he's talking about here. Like, did you guys know that if you get a traumatic brain injury, that could also result in mental illness later? Yeah, like this is like a known, this is not a secret.
Is mild traumatic brain injury is a major cause of psychiatric problems, and nobody knows it because psychiatrists don't look at the brain.
The DSM has explicit categories like neurocognitive disorder due to traumatic brain injury, and there are entire psychiatry and neuropsychology guidelines, toolkits, and textbooks for working with TBI patients.
Family doctors don't look at the brain in this person who's having problems with domestic violence, or this person who's been incarcerated 3 times, or this person that is homeless. And no one's thinking, did that car accident damage their...
Like, fuck, not to meme too hard, but like even fucking House episodes, there have been episodes where it's like, oh, your son had a brain injury, you didn't think to bring this up? Like, this could actually be causing this other illness. Like, everybody, I don't know, this is, whatever. Okay, it's okay.
Right.
So are psychiatrists who are not using brain imaging, by functioning without looking, are they doing a disservice to their patients?
I think they're flying blind. And they're missing so much that could be gotten from imaging. Is your brain hurt? Is it toxic? Is it overactive? Is it underactive? Like, I'm a psychiatrist. Why do I care about Lyme disease? Because it's a major cause of
Oh boy. Also, and I know Dr. Mike likes to do podcasts kind of for laymen or whatever. I'm not to say it's like for retards or whatever. But there would be times where I'd be interested, like, can I get like I need like the ultra educated man's podcast, like drop some shit on me. Like when he says this brain looks different from that brain, what exactly are you talking about there? Like, are you measuring specific regions in the brain? Are you measuring activities of certain neurotransmitters? And we can fucking wiki it or look it up later, or they could talk about it. But I wish you would get a little bit more into that instead of just making the generalized statement, because both these guys are educated. They both should be able to talk extensively about it. Like, get into it. Maybe they will later on, you know?
Psychiatric problems. Yeah, I think as a profession, we can do so much better.
Mm-hmm. And you mentioned...
And that's why in medical school, psychiatry is sort of looked down on. It's like, really? That's
well, is it looked down upon because it's the lowest reimbursed field out of all of the specialties?
No, I don't think so. I think it's looked
family
down
medicine, pediatrics, and psychiatry are the lowest ranked fields. And they're the lowest paying
those were the 3
fields.
I was interested in when I was a medical student. Because it wasn't about the money. It was about where I could do the most good.
Sure. Well, we definitely need the most help in those specialties. Because I think a good primary care system is the backbone. I don't know if you agree.
Absolutely.
With a good healthcare system.
No, you should have a wonderful family medicine doctor. But, you know, most people use the emergency room.
Or urgent care, where there's no continuity. And it's
right. There's a relationship. Yeah. And I trained in the early 80s before managed care took over medicine. And I'm so grateful that I did, because in the early 90s, psychiatrists became the prescriber, and they just ruined the profession. Like for me, I was taught to do family therapy and group therapy and individual therapy, and medicine was just sort of a part of what I did. And I wouldn't be happy if I was the prescriber.
Probably in the same way that I can relate to that in being a family medicine doctor, there are a subset of family doctors who have trained to be referrologists. Who, oh, you have high blood pressure? Here's a cardiology referral. Oh, you have UTI? Here's a urology referral. You don't need to do that. I constantly have to remind my residents that 90% of all medical ailments can be handled by a primary care doctor. And there are subsets that are complex, that require specialist intervention, procedures. We don't do colonoscopies as a simple one, surgeries. So there's a lot we can handle, and I think there needs to be improvement across all these fields, especially in the area of education. So much how you're talking about the prescriber, I'm talking about the referrer.
No, I love that. It's the first time I heard that term. Yeah. And it's like, no, that's not why we went to medical school.
Correct.
Right?
And
we had to take all of those rotations.
Exactly. And we forget them because it's easy to just refer. It also shifts the legal concern. Oh, well, I sent you to the cardiologist. They made the decision. It takes the decision-making pressure off me. So I don't like that in terms of practicing medicine that way. So I agree with you in that regard. You mentioned some of these brain classifications that you do to see if someone has a ADHD type brain. You know, we have all of these validated PHQ-9s, GAD-7s, Vanderbilt, MCHATs. These are questionnaires we give to patients. Sometimes we give them to parents, to teachers. Do you not like those ways that we make
give them to our patients? But depression is clearly not one thing. Anxiety disorders are clearly not one thing. Now, you get a high GAD-7. So what do you do with that? Do you give them a benzo that's addictive, that increases their risk of dementia?
I mean, that's out of standard care.
You don't, but
that's out of standard care.
27% of all doctor visits, someone's getting a benzo. This is
poor medical
insane.
What? In a JAMA serial cross-sectional study of 386,457 ambulatory care visits from 2003 to 2015, the use of benzodiazepines in ambulatory care increased substantially from 3.8% to 7.4%. Okay, so for ambulance, those might be certain types of disorders or something that maybe, like, this is not going to be the standard person going to the hospital, somebody who's going through an ambulance, right? So this is a subset. Also, he got that wrong by an impressive amount.
You give them a benzo that's addictive, that increases their risk of dementia.
I mean, that's out of standard care. That's out of standard care.
27% of all doctor visits, someone's getting a benzo.
That's so egregiously wrong there. A quarter, even for me, that hit the whatever bullshit. A quarter of all doctor visits is somebody getting a benzo prescription. Ambulatory care is not ambulance. Oh, I assume that means somebody coming via ambulance. Okay, hold on. Ambulatory care, what does that mean? First, medical services performed on an outpatient basis, allowing patients to receive diagnosis, treatment, and consultation without an... Oh, so this is outpatient. Okay, so if I were to go to... like an urgent care clinic, get something prescribed, and then leave, that would be considered ambulatory care? Okay. If I do... if I have like a doctor appointment, and I go to an appointment, and as a part of that appointment, they prescribe me something, is that considered ambulatory care? Yes. Okay. All right.
This is
still quite a bit off that. What do you say? A quarter versus 7.4%.
For medical care. But
insanity.
that's not what the agencies recommend, right? If we were to go on to the APA or any of these organizations, they wouldn't say that that's standard.
I mean, hopefully you teach them diaphragmatic breathing. You give them things like theanine, maybe from a medicine standpoint.
That does seem pretty high, though. 8 to 9% of all doctor visits included a benzodiazepine prescription.
Propranolol.
For 2014 to 2016.
But that's not...
I mean, now we're even introducing allergy medication for people who have anxiety. So
yeah, the antihistamines would also increase the risk of dementia.
Yeah, for sure. Overuse a lot of it. But I mean, every medication has some sort of trade-off.
Right, but teaching someone not to believe every stupid thing they think and teaching them diaphragmatic breathing, no side effects, no increased risk of dementia, probably decrease the risk.
It sounds like you're a fan of therapy, of cognitive behavioral therapy. Are you?
Absolutely.
Okay.
And I think family doctors, if they just learn some of the basic principles, right?
What you said, we've scaled back benzo prescriptions a lot. Okay.
I talk about killing the ants, the automatic negative thoughts that steal your happiness. Whenever you feel sad, mad, nervous, or out of control, write down what you're thinking and just ask yourself whether or not it's true. And in the book, part of the doom loop is an invasion of ants, these automatic negative thoughts. And there's nowhere in school where we teach kids not to believe every stupid thing they think. I was 28 years old in my psychiatric residency when one of our professors said, you have to teach your patients not to believe every stupid thing they think. And I'm like, but I believe every stupid thing I think.
Revolutionary idea.
Right? It's like, but that's such an important concept. You know, if patients came in knowing how to manage their minds, they're going to have a lot less back pain. They're going to have a lot less neck pain because negative thinking goes to more tension, which then leads to more pain.
Yeah, we talk about that a lot on the channel. Are you familiar with Dr. Sarno's work?
Love Dr. Sarno's work. I talk about him in the new book because what he basically says is chronic pain is repressed rage. But he doesn't do a great job of helping people get rid of the rage. And so in the book, Pollyanna actually meets Hannibal Lecter because you have to have a mechanism to get in touch and express the rage in an appropriate way while you're directing your mind to what's right rather than what's wrong.
Are benzos prescribed for anxiety? I think generally, wasn't that their main use? I don't know how often it is anymore, though. I'm not a doctor.
Yeah, I think he was ahead of his time to some degree, and people will point out flaws of, he had this theory of increased muscle spasms due to decreased blood flow to a specific area. And when that was somewhat disproven or questionable, he threw out all his theories. And I feel like as someone who's practiced medicine for over a decade, I've seen his theories play out, not just from, I see this happening with my patient, but direct intervention in handling anxiety, stress, childhood traumas, just discussion of those issues leading to elbow pain going away. So I believe that there's definitely a variable there. Sometimes it's hard to get patients on board though. I've had patients get very offended at me when I say, hey, what's going on in your life emotionally? What was your upbringing like? And they'll say, why the hell are you asking me this? And I explain, they say, well, you're one of these asshole doctors that just wants to blame it on me. And I say, no, quite the opposite. I'm explaining that you have an internal regulator that basically dials up volume when you're stressed, as it's supposed to as part of its survival mechanism, and then down regulates when they're having a good time. Because you just told me that your pain is only there when you're working, but not when you're having fun with your friends. But it's still sometimes hard to get buy-in. What's your strategy on getting that buy-in?
People say,
the imaging.
I think it's all in my head.
Show them the
absolutely, but it's
image.
in your brain, which is in your head. That if you've had pain for more than a couple of weeks, that now has a signature in your brain. And if we don't get your brain healthy, the pain's going to stick around. And one of the reasons I wrote.
Wait, what did you say? Oh, bro, why are you fucking bringing this motherfucking trouble to me? Dang.
Change your brain, change your pain. I'm 71. Is I just got tired of being in pain all the time. It was my back, it was my knee, it was my neck, it was my hip. And I'm like, what is going on? So read Sarno's work, started looking at the scans of our patients in chronic pain. And I'm like, oh, pain gets stuck in your brain. And the one study that just completely blew my mind was 80% of people my age have abnormal backs who have no pain.
Oh yeah, that's
who have
the classic
no
example.
Pain.
Why try and talk patients out of MRIs for their spines just because?
And
oh hey,
what I have found that when people go get them after I teach them this, their abnormal neck doesn't freak them out, so they automatically go get surgery. They go, oh, 70% of people my age have abnormal necks who have no pain. So it means your body can figure out how to heal.
Just to be clear, I don't believe that at all. I think that if you start showing patients a ton of shit and they see something that's weird, the doctor's like, oh, no, trust me, that's fine. As soon as anything goes wrong in their life, they're going to be thinking exactly back to that particular thing. 1,000,000,000,000% though.
My age have abnormal necks who have no pain. So it means your body can figure out how to heal around the arthritis in your neck or the crushed disc in your neck.
I mean, like, I don't, bro. I feel bad just like talking shit because I don't know. Maybe it feels like this guy should have so much. Like, if your neck is a weird way just because that's the way that your body's blueprint and everything grew it out and it's just kind of like strange, I feel like the resulting things from that person's neck being weird is going to be a lot different than a person's neck being weird because they fell off a fucking chair and they hit it on a sidewalk. Like, it's not because it doesn't mean that one body's neck has healed successfully. It could just look different because they grew up or because their bone structure or whatever is just a little different. I feel like that is a complete non sequitur, but
heal around the arthritis in your neck or the crushed disc in your neck. And that's so freeing to me. And it's like, if I calm my brain down, my pain's going to be less. And now I'm in no pain at all, which I dearly love, because it doesn't freak me out if I wake up and my neck is sore.
Sure. What do you say to patients? Because I've had this end up even with the patient filing a complaint against me. I have a whole video on the channel about it, where I was trying to discourage the patient from getting an MRI for low back pain that I believe not to be from a spinal cause based on my physical exam, the history of present illness. And I felt like there was an emotional component. I introduced it. I asked how they feel about that. They said, I still want the MRI. I said, I'm happy to order the MRI, but I'm just explaining that if we find something on this MRI, we're likely to end up chasing it when it's not the cause. And she didn't like that answer. So I'm curious how you go about avoiding unnecessary imaging in those cases.
Well, I'm a huge fan of informed consent. This is, do we agree on what the problem is? So back pain. Okay, you have back pain. Here are the things we can do. And here are the pros and cons of those things. What do you want to do? You decide.
I feel like I hate this guy. I'm sorry. Okay. All right. Hold on. I feel like I've done this as multiple Dr. Mike interviews. Okay. I'm not hedging for the rest of this. This guy's a fucking quack. Okay. Dr. Mike's question was a very easy question. What do you do to avoid patients having issues because you're ordering images that they don't need and they're requesting the imaging anyway, and then they get the imaging and then they see something they think is concerning, but you, with your infinitely greater training as a doctor, are like, trust me, that's not a problem. That's not an issue. I know it looks bad, but this is not an issue. And then the patient gets stuck on it. And the guy's response are platitudes. I hate educated people that speak in platitudes. Platitudes are for doormats and kitchen towels. Like, if he's asking you a serious question, you should give him a serious answer. How do you prevent people from falling into the trap of diagnosing things about themselves because of imaging you get? I'm a big believer in informed consent, and as long as we're on the same page, you're the driver, buddy. What a retarded fucking answer. So you don't have an answer because you are the guy who likes the excess imaging, probably because you make a fuck ton of money in your own little private clinic or treating and killing people like Scott Adams on the side is my guess.
And if I've done a good job of connecting with them, generally they'll choose what my recommendation is, but not always. And as long as it's not irrational, I feel like I work for my patients. I don't work for the insurance companies. I work for my patients. And generally that works out for me. And I think works out for my patient, because if they do something that, I don't think I would have done it, and it doesn't work, they trust me because they feel like I'm their partner.
So
like, imagine like your fucking 8 years of schooling and 3 years of residency and your year of whatever sub-residency and all this shit and your intern, your sub-internship. I don't trust you for that. We need to do some fucking bullshit testing, and then if the bullshit testing leads to nothing, now I'll trust you, doc. Like, really? That's the route we're going? Okay.
Saying perhaps I didn't form a good doctor-patient alliance with this patient.
So alliance is so important. I mean, I don't know, because I wasn't there, and you probably were as kind and empathetic and listening as you could have been. One of the things I learned is, and I guess I'm free associating, you have to ask patients 10 times whether or not they've ever had a brain injury. It's shocking to me. So I start imaging, like, have you ever had a brain injury? You can see the damage to the left front and to their anterior temporal poles. It's a sign of traumatic brain injury.
My patients, it's House! He's House! Everybody lies! Oh shit, he's actually secretly based. Everybody lies. Order an MRI. We don't trust this guy. He's on withdrawal from alcohol. Search the house. I want to hear that next. He's like, so sometimes we break into patients' houses. We just search for shit. Like, I don't really trust the patient history, so I just went ahead and I did a full fucking, blood blood panels and X-rays and PET scans and everything. Because why the fuck not? Let's go.
And they go, no. I'm like, well, are you sure? Have you ever fallen out of a tree, fell off a fence, dove into a shallow pool, had a concussion playing sports, been in a car accident? No, 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 no. Oh, it's always no, no, no. Oh, I fell out of a second-story window when I was 7. Do you think that counts? Or I fell out of a moving vehicle going 30 miles an hour. Do you think that counts? And I just think it's one of the major causes of psychiatric problems.
So when you have a patient that you come across with a history of falling out of a window when they're 7, how do you alter your approach to treating that patient?
Well, we go repair the brain injury, right? If you don't do that, then...
Like, does he must recognize it, right? How do people do that? I wanted to learn this because it'd be nice to be able to do these like kind of debate tactics to mindfuck a person. Like, he just doesn't engage with the question at all. So you encounter a patient like this, so what do you do differently? I'm just going to tell you what I do all the time. Oh, so you don't differentiate. Why not just say, like, okay.
They're going to be living with chronic, whatever, depression, irritability.
Not surgically.
No, put them in a hyperbaric chamber. So I did the big NFL study when the NFL was sort of lying. It had a problem with traumatic brain injury in football. Right, everybody knows CTE. And they had the wrong thoughts on CTE, which we could talk about. But in 1999, Brent Boyd, who was offensive guard for the Minnesota Vikings, came to see me, clearly had traumatic brain injury on scans. And by then, I'd already been scanning people for 8 years.
Like, was that the big breakthrough? Was the big breakthrough that they do have a ton of injuries, or was the big breakthrough that people were maybe underplaying the chronic impact or whatever of these injuries and the impact they were having on like people's health and their chronic impact? Like, we didn't. No one actually knew how damaged NFL players' brains were until we actually imaged them. I feel like the thing that they were downplaying was like the actual impacts it was having on their health. No, but I don't know.
He filed a workers' comp claim. The NFL said he was faking and called me a quack and just completely dismissed it. Well, in 2007, Anthony Davis, the Hall of Fame running back from USC, came to see me. His brain at 54 looked like he was 94. But 5 months later, he's dramatically better. And we partnered with the NFL Players Association in Los Angeles, published the first largest study on 100 active and retired NFL players, high levels of damage. But 80% of our players got better. We put them on a really good multiple vitamin, high dose, high quality fish oil, and a brain supplement that works in 6 different ways.
Oh, it's the fish oil capsules for my fucked up brain from getting smashed in the head 4 million fucking times by dudes that are 6'4", 300 pounds. I need the omega-3 fatty acids. Fuck, what was I thinking?
80% of our players got better. Their imaging was better. And for those that didn't, we put them in a hyperbaric chamber, and that improved our outcomes even more.
Yes.
So I'm really excited. So the idea is, okay, boxing, football, soccer, rugby, horseback riding, they're brain damaging sports. But you can get better if you put the brain in a healing environment. So we specifically target repairing those parts of the brain. And I own a supplement company, so I'm a huge fan. But I'm also a huge fan of hyperbaric oxygen therapy. Published a study on soldiers who had blast injuries, showed significant improvement after the...
If there are things that are like good for you, having those things in huge doses is always going to cure every single underlying ailment. This is why 1,000 milligram super shot, 10,000 milligrams, 100 of vitamin C is like amazing for you. Water fasting will detox your body and cure cancer. If a thing is good for you ever in some amount, then just upping the amount will just cure diseases. It's amazing. Okay.
First session, and then...
So oxygen is... I'm talking about hyperbaric chambers, increased percentage of oxygen for the atmosphere. Is that what hyperbaric is? I think it is, right? Is it 100%? Is it always 100%? Does it have to be 100%? But yeah, so oxygen is good for you. So more oxygen, okay? Whew, that's just gonna fucking fix everything.
Much more after.
Plus the fish oil capsules. Don't forget those.
You're the owner of the supplement company. How do you protect yourself from the conflict of interest that can happen?
Oh, he owns a supplement company too. Oh, thank God nobody's figured out the slur terminology for big supplement. Thank God nobody's talking about big supplement. Oh, he owns his own. How convenient.
Who had blast injuries, showed significant improvement after the first session, and then much more after the 40th session.
You mentioned you're the owner of the supplement company. How do you protect yourself from conflict of interest that can happen in scenarios like that?
There is no conflict of interest. You're always right.
I write about the research. I love what we do. I'm so proud.
Oh, he loves what they do. We're just making money. Oh, he loves what they do. This guy's got all the best answers. I would expect nothing less from a doctor who sits in hyperbaric chambers every day. God damn. Whoo.
Of what we do. So, for example, we make happy saffron. 28 randomized controlled trials, 30 milligrams of saffron, equally effective to antidepressants. So
Equally?
I think my
To
job
all of
is
them?
Just one, tell people I own a supplement company. So
Clear disclosure.
people know it. And then write about the science behind the ingredients we have. And so I always say no brand violations, that we only want high quality things that have efficacy. And I love that. So it's not a secret.
I love it too,
Brain
Rick.
MD by Dr. Daniel Lehman. Yeah. And people go, oh, but he makes money. Well, I'm like, no margin, no mission. It's like, that's not illegal, right? All doctors get paid for what they do. But I love it. And after we made Happy Saffron with saffron, zinc, and curcumins, there's a brand new meta-analysis on 192 studies on 17,000 patients. Saffron effective as an antidepressant. But when you add zinc and curcumin, now this is true.
Oh,
you add it
that
to
zinc is a
saffron-
big one too. Zinc's always up there. What are the big ones? It's like zinc, vitamin C, the omega-3s. Fuck, can I think of another one before he says it? I haven't heard the saffron one before. Okay, that's a good one. Oh, magnesium is going to be one. Absolutely, you gotta have magnesium in there. That's true. Okay.
Or Lexapro. If you add zinc and curcumins, they actually work much better. So I was very happy that I figured that out before.
For the conflict of interest portion, people always, I get this sent to me, you're a pharma shill, you prescribe medications, therefore whatever you're recommending is not good. And we hear even Secretary Kennedy of HHS now say similar things. Basically, people badmouth pharma because they're for profit. Do you think that's unfair?
Absolutely. I mean, there are other reasons to badmouth pharma.
Like what?
But
Careful.
we absolutely need
Like what? Like what?
pharmaceuticals.
Like what? He said like
And
what?
For the right brain, they're incredibly effective. And if the companies didn't make money, they wouldn't be in business.
Yeah.
And I'm a huge fan of medicine and prescribe them when I think it's appropriate. And I'm a huge fan of supplements. And why? Why did I get interested in supplements? When I started imaging, I realized some of the medications I was prescribing were not good for the brain. And you remember in medical school, they go first do no harm and use the least toxic, most effective treatment. And so if omega-3 fatty acids head to head against Prozac were more effective in a study from New Zealand, well, why wouldn't I start with that?
Well, it depends how
saffron?
severe the person's symptoms are.
Well,
If someone
that's-
is having
Size of the effect is unlikely to be meaningful to people with MDD, and we consider the evidence to be of low or very low certainty with many differences between studies. Rip.
radiation, you don't want to start with omega-3s.
Well,
This guy's getting brutalized on the fact checks.
nothing
I think he's been wrong on every single one.
by itself, right? If you look at the studies, there's not much that works by itself for the most severely depressed people. And I would argue it's because often it's not only the depression, but it's the head injury that's complicating it, or it's the infection. Yeah.
You mentioned
but
that,
that's why I got interested in it.
yeah, you mentioned there are some reasons to be critical of pharma. What are those?
Uh-oh.
Well, I think that they market them nonstop. And so they almost creating the market for it.
How is that different than your supplement line?
Now we're starting to ask the big questions. He's buttered him up for 38 minutes. Whew, let's go. Let's go!
That's a good question.
Wait! What? Did we do there has to be a name for this thing. I say these are the level 1 questions. There has to be a name for this phenomenon where you ask a person a question that certainly they don't even have to have heard this before. They should have thought of this on their own, right? This is the stealing is always wrong, and I think you should kill people who steal. It's like, what if a person steals because they're starving to death, and they're like, oh shit, that's a good question. Oh, I've never thought about that. It's like, how wouldn't this be the first? Wouldn't you think of this question yourself? Let alone any other person would think to ask you that question. No, you haven't. Like, I would imagine. Well, that's because I try to be good faith, I guess. If I was a retard, or if I just wanted to be bad faith, maybe I just wouldn't give a fuck. I would imagine going into a thing like this. Okay, I'm a huge critic of big pharma and them selling shit, but I have a supplement company. I need to have some really good answers to differentiate between these two things, because obviously any good faith actor is going to hit me on those points relentlessly. Don't you have a whole ass supplement company and you're standing in opposition to big pharma. What differentiates the two of you? And he's saying like, well, evidence? Oh, big pharma doesn't do studies? What? Are they just fucking publishing shit at random and then throwing shit in people's mouths to see what works? Like Trump did to little. Just kidding.
How is that different than your supplement line?
That's a good question.
Go ahead. You got an answer.
Supplement companies like mine don't have nearly the money that pharma has.
Wait, is that true, or am I mixing that up? There's always a claim made about like the size of supplement versus like, is the supplement industry bigger than the pharma industry or not? Let me check. Hold on. Supplement industry size versus pharmacy industry size. Oh, I bet it depends on how you value it as well. So the AI answer for Google says the pharmaceutical industry is significantly larger than the supplement industry, with the global pharma valued at over 1 trillion. And then they value the global dietary supplement market at roughly 200 billion. But then they also say on this site, the global wellness market is now 3.4 trillion, which is nearly 3 times larger than the 1 trillion worldwide pharmaceutical industry. I wonder how much you count as like pharmaceutical and how much you count as, this says the supplement industry is 54 billion. And the wellness industry, I wonder what is, I don't know. I don't think the supplement industry is lacking for money. I'll say that much. But
and supplement companies like mine don't have nearly the money that pharma has. And so...
Well, the Global Wellness Institute estimates that the wellness industry is a $2 trillion a year industry.
Oh, this was the one that I just popped up from you.
In the United States. And Big Pharma is 700 billion.
That would shock
He's using the lower end of Big Pharma there.
shock me, right? Because I own a supplement.
What do you mean that would shock me? You don't know? Shouldn't you? You own companies in this world. You wouldn't have any idea? You're completely clueless on that?
And Big Pharma is 700 billion.
That would shock me, right? Because I own a supplement company, knowing our budget as opposed to Eli Lilly's budget.
But you're not the largest supplement company in the world. Why would that be the comparison? Like, did you know that Americans make more money than Somalis? Well, that would shock me because I work at McDonald's and I know a Somali guy who makes fucking $250,000 a year, who is like royalty and small. Like, what is that compare? What that's like? It's not even dumb. It's like that's a huge breakdown in critical thinking.
It's like we're not even talking the same thing, or even the very large supplement companies. So,
wait, is that true or is that not true? I don't know if it's true or not, but
just don't know the.
Yeah, well, let's take the numbers out of it because that needs to be fact checked. But let's say for those who want to advertise a supplement, like if I want to start my own supplement company, we have 14 million subscribers, very healthy YouTube channel, very active audience. If I wanted to start a supplement company, it wouldn't take much. I have to get someone to give me the ingredients, to create the label, send it out. But pharma has to go through trials. The FDA has to approve it. They have to spend
bought and paid for.
Don't you think it's
do the
easier
rotating
to create a supplement than it is to create a pharmaceutical?
Rotating and lobbyists.
Yeah, no, I think absolutely you're correct. And there are a lot of bad actors in the supplement world. So finding somebody you trust is important.
What's a bad actor in the supplement space?
Well, somebody who doesn't test the ingredients, someone who you don't feel confident what it says on the label is actually in the bottle.
So how does an average person to decide that?
I think they have to
Look at the
find
studies.
brands they trust.
Oh.
Consumer Reports.
Oh, how does the average person? They need to find brands they trust. Oh shit! How does the average person deal with diabetes? Well, they need to get rid of their diabetes. Oh, how does the average person deal with like high blood pressure? Well, they need to lower their blood pressure. It's crazy that the answer to a how is just a what, I guess, is just what you need to do. Okay. King.
Does analysis, does independent testing. There are other companies that do that.
Yeah, like Consumer Labs, Consumer Reports have done a lot of these trials, and they go to the local pharmacies. They take things that are top selling, and they find 70% of them don't have accurate ingredient lists. Shouldn't that worry people about the supplement industry?
Uh-oh.
And I think they should be cautious, careful.
How does he just walk back on every fight with no pushback at all? How does he just walk back on everything?
And again, I'm trying to figure out what practical advice to give them.
Yeah.
So
hello?
How can they be cautious, careful? They can't test what's in there, which is why I think the
they
FDA
can go
tests.
to a place like Consumer Labs.
Okay.
And go which are companies that are
we can trust.
reliable, consistent.
Oh, okay. Okay.
I think that's my best advice. But before I had my supplement company, I would do that and recommend certain brands for my patients.
Oh, okay.
And if
so trust your doctor? Is that what he just said?
The FDA currently doesn't look at supplements, right? But they look at the pharma industry to make sure everything's standardized, validated, efficacy rates are tested. Even if pharma markets a medication for a use that it wasn't initially approved for, they get in trouble, right? They get huge fines.
The FTC, the Federal Trade Commission, if you're marketing a supplement inappropriately, they'll send you a letter, they'll fine you, they'll put you out of business.
Yeah, you have to be somewhat careful because I looked into starting a supplement line. If you don't say that something clearly cures something and you just say balanced brain or healthy energy levels, and you don't clearly say that it does that, you can get by making all sorts of claims. And historically, people have destroyed their livers with some of these supplements, the hydroxycut scandal of years ago. So there's all these...
It's a quasi yes and show. Mike asks the right questions, but he's too nice. I mean, I think Mike is trying to balance his access to these people, right? Like if you go full Destiny, then no one's going to want to come and talk to him. So he's trying to balance like, how do I get people who even want to come on the show because they know I'm not going to fucking roast them, versus also trying to be responsible in his platforming and communicating of things, you know? It's challenging.
So it's a kind of the Wild West out there when it comes to these supplements.
Yeah, but I read one study. Your chances of dying from a supplement are like 60,000 times less than dying from a medicine.
Like, yeah, that's because a lot of supplements fucking don't do shit. Yeah, what is... I bet your chance of dying from meditation are even lower. Like, what is the... An estimated 23,000 emergency department visits in the United States every year are attributed to adverse events related to dietary supplements. Oof. The brutal fact checks.
Now, it doesn't mean that you shouldn't be thoughtful and careful on what you put in your body. You absolutely should be.
Okay.
But when we look at pharma and the level of death from pharmaceuticals, it's not even the same league with supplements.
So death is the way you judge the safety of these medications?
Well, it'd be one way.
Well, sure, but the idea that 70% of them don't have the thing in them, that's pretty problematic too. Imagine the pharmaceutical industry turned out that when we tested their medications, they didn't have what was in there. Their insulin was only present 70% of the time. That would be a big deal.
You know, I can only speak for BrainMD, and I'm very proud.
Yeah. Do you think the FDA should be out there randomly sampling and testing to make sure that these supplement companies have what's written on the label?
I think it's a good idea to police whatever people put in their bodies.
Yeah, I'm always for that, just because right now it's, again, such a Wild West. Even Consumer Reports published recently a study of heavy metals inside protein powders and how people can be inadvertently trying to be healthy, but perhaps getting, especially
the lifting community really didn't like that one.
Bodybuilders, scoop.
But the true gods realize a little bit of lead poisoning makes you more hard-headed, makes you more resilient, okay? That's actually good. I didn't know. People were out here being like, oh, fucking lead in your fucking protein powder. Okay, but the true lifters were like, I'm getting free lead? I'm getting free lead supplements in my protein powder? Whew, that's why he's been so Giga Chad lately. Hell yeah.
Before you know it, you can get a serious problem developing there. And some of the brands are very legitimate, very popular brands that you see selling quite well. So I'm always trying to figure out what's a safe recommendation that I can give universally to my patients. I'm curious, we never kind of settled on our question about the compliance issue. That you mentioned that getting these imaging tests is valuable.
This guy is getting the most gentle questioning of all time. It is so gentle. And this guy's like fucking pressed as fuck. He's so pressed right now. Holy shit.
Compliance. And I was talking about how it could potentially scare people away from seeking healthcare from a mental health care, specifically from a provider who doesn't do imaging. Do you have any fear that you might be discouraging patients from getting good quality medical care or mental health care just because they're not doing imaging?
Nah.
Well, I guess, you know, the question I have is, do you really get good quality brain health, mental health care if you have no idea what's going on
well, that's a good question. Yeah, maybe you can answer
that
Are
you're
you?
treating? I don't think so. I mean,
Really?
I wanted to write a book once called Flying Blind and the Brain of the American Mind.
Wow.
And,
Dark.
And I'm sort of sad I didn't write it. I actually had a book deal for that book. And I'm like, oh, it's just too negative. But what is happening in American society today where 57% of teenage girls report being persistently sad, or that it has increased significantly in the young since the year 2000? That with all this sadness, the use of antidepressant medication has skyrocketed. 2021, there were 337 million prescriptions written for antidepressants, and we're not teaching people how to love and care for their brains or manage their minds. And I think if we imaged, that people would care about their brain a lot more. They would just eat better, think better, and do a better job of taking care of themselves. So I think we're in, I call it a whole 4 crisis. We haven't talked about this, don't we?
A whole 4 crisis? What do you say?
We're in, I call it a whole 4 crisis. We haven't talked about this, don't hate me. God, it's so frustrating. I'm working with the White House on a national brain health revolution initiative, specifically with the White House Faith Office, because they believe that brain and mental health are sacred human rights. And
health war crisis. Okay.
I have people that just love me and support my work there. And as I explain it, we're in this whole 4 crisis. We're in a physical health crisis. I think you and I would agree with that. With
Chronic
75% of people overweight or obese, 50% diabetic or pre-diabetic, 90% of our healthcare dollars are spent on chronic preventable overweight or obese, 50% diabetic, 75% of people overweight or obese, 50% diabetic or pre-diabetic. 90% of our healthcare dollars are spent on chronic preventable illnesses. We have these epidemics of anxiety, depression, autism, ADHD, addiction before the pandemic, and then everything got worse. Loneliness, 58%. So biological, psychological, social, spiritual, where 58% of young people report a lack of meaning and purpose. But I believe the answer to these epidemics is not to see them as separate disorders, but as different expressions of the same unhealthy lifestyle that have exactly the same cure, which is getting your brain, mind, relationships, and spirit healthy all at the same time.
Yeah, you're looking at it more holistically.
Right. I did a program with Pastor Rick Warren called the Daniel Plan. It actually came out of a prayer. I went to my church. I just finished writing Change Your Brain, Change Your Body. It's 2010. Went to my church on a Sunday morning. I was so happy and walked by hundreds of donuts for sale for charity. And it just pissed me off. I'm just like, I'm going to church to get my soul fed. These people are trying to kill me. And I prayed God would use me to change the culture of food at church. And 2 weeks later, Rick Warren, who is our generation's best-selling author, he wrote The Purpose-Driven Life, sold 50 million copies. He called me up. He said, I'm fat. My church is fat. Will you help me? And we created this program called the Daniel Plan that ended up being done in thousands of churches around the world.
Wow.
And I go, how do you get people healthy? You get them healthy where they live, whether in their community, in their churches, in their businesses, in their schools. And that's part of this sort of national brain health revolution.
Yeah, this mental health crisis that we're facing, we have, as you said, teenage girls experiencing high level of sadness. The amount of SSRI and antidepressant prescriptions are going up and up. You think this is partially due, or maybe majority due, to the fact that psychiatrists are raping their brains?
I think that
Is that what he said? Raping their brains?
Due, or maybe majority due, to the fact that psychiatrists are raping their brains?
Wrecking their brains?
I think that as a specialty,
Why is that censored?
we have gone to be the prescriber rather than the healer. That antidepressants don't cure anything; they suppress symptoms. I think.
Do they say that it
obviously
cures
it's
it?
not psychiatry's fault.
I've never heard a psychiatrist say that antidepressants cure depression.
You don't hear that.
Yeah.
That it cures anything.
Right.
Right. I heard once John Paul DeJoria speak. He founded Paul Mitchell, the famous shampoo company. He said, you never want to be in the order business. You always want to be in the reorder business. And, once you start these medications, people don't stop them.
Well, the goal is not to use them indefinitely. I think the correct indication is to create a bridge to get people over the
And
life
how many
event.
of your patients, once you start them, stop them?
Almost
Apparently the median was 5 years is what it said. He's going to say almost all of them?
all.
Nice.
I have a rule that if
And he's laughing because he doesn't know the data. You should know this. You should know the data on this, right?
we're starting an antidepressant, we're creating
Wait, did you catch that? Go back 20 seconds. Wait, which dumb
The
thing?
order business. You always want to be in the reorder
This thing? There's another big pharma bad thing. Or
business. And, once you start these medications, people don't stop them.
well, the goal is not to use them indefinitely. I think the correct indication is to create a bridge to get people over the
And
life
how many
event.
of your patients, once you start them, stop them?
Almost all. I have a rule that if we're starting an antidepressant, we're creating a date that both me and the patient are comfortable with, where we're doing reevaluations, whether or not they feel that they're in a safe place to come off, given their circumstances.
he's going to say, well, good for you. You're 1 in a million, babe.
Because being in a community health center, I'm working with people who are disadvantaged, who are taking care of multiple children on their own, family members in prison, and as a result,
Also true. That would be a good counter question for Dr. Mike. What's an example of a supplement that you only have to take one time? Just curious. Or is there a supplement that you don't have to reorder, or is there one where you can take your one and done? Because talk about the reorder business. Yeah, Jesus.
they need the antidepressant. They don't have the capacity to get scans, to get a hyperbaric chamber. It's not feasible. There's the perfect model, and then there's the realistic model by which a lot of family medicine doctors have to practice by. And
We're talking about two different things. Yes, I think in this situation, but most people who start stay on them. Most people who
Forever.
start don't have Dr. Mike that go, we're going to
see?
start this.
But that's
and
not
then
true, right?
We're going to reevaluate it and work on getting you off of it. That's not been my experience.
I agree
Oh,
with
your
you.
experience.
I think there's a lot of reasons to that from what I've seen in the medical community. A big part of it is the consumerization of it. You know, we blame pharma for marketing these medications when I have seen patients say that I'm not getting rid of this. This helps me and I need this and I can't function without it. And if you're not prescribing it to me, you're evil. And perhaps they are right in some instances. So I don't want to discredit what they're experiencing. But in some instances where I feel that we should be having that discussion, some patients aren't open to that.
Well, and ultimately, I think my job is informed consent, like we talked about
just let
before.
them choose.
But head-to-head against antidepressants, exercise is equally effective. Head-to-head
Again, there's a lot of
Like, okay. But like prescribing exercise?
caveats that need to
But
be made there.
head-to-head.
But it's
learning
not-
how not to believe every stupid thing you think is equally effective.
Oh,
and
wow.
omega-3 fatty acids and saffron.
Yes.
And so I'm
Yes.
thinking, let me at least go because a lot of patients who come to see me, they don't want to take medicine. They're like,
Oh.
anything
Which is
I
why
want
I
to
think
do.
our worlds are so different. You're having this pre-selected, highly motivated, treatment-preferred specific group come.
Oh, he's talking shit now. That's a big one. Oh, that's the difference. I have real patients, and you're getting people that are looking for a bougie, like a Beverly Hills doctor. I want the most exotic shit you can give me because I'm too cool for normal medicine.
to you versus I essentially function in the wild and you're working in a zoo, for lack of a better example, with
Well,
domesticated animals.
I was an army psychiatrist for 7 years.
For sure.
And
But I mean, in your
loved
clinic.
it.
And here, those patients aren't super excited about a specific approach.
Yeah, no, people come see me are excited about it. Then
Do you see that?
That's not, you didn't mean that as a compliment, bro. You mean your patients are motivated to seek a particular type of treatment.
Huge advantage.
But then a lot of them, grandma's paying for them to come see us, and they're not super excited. And we have to get them excited, and the imaging really helps that.
Well, let's talk about the imaging, because Kim Kardashian recently got some imaging done, and you found some results on her. Tell me about that.
Uh-oh.
She had sleepy frontal lobes. And
Sleepy lobes.
so SPECT is a study of relative blood flow. It looks at activity. Actually, 49% of the tracer is taken up in the mitochondria in the brain. And she had less activity in the front third of her brain, which means it's going to go with things like forethought and judgment and impulse control and focus. And she wanted to be better. She's in law school and getting ready to take
So like this, I'm confident in saying this. This is like one of the number one, like, I don't know if you'd call this amateur areas of like medicine, or it's one of the dumbest things is you have a hypothesis for a particular thing in the body causing a particular condition or behavior. Those two things can't be taken for granted. You have to establish that link with like some kind of behavioral research. So you might think that this part of the brain is responsible for memory, and when I do this scan, I can see that the blood flow is reduced. That's a hypothesis. You can't prescribe anything at that point, assuming you don't have like already like a standard of care. If you're doing research, this is where you go, okay, well, I see that there's less blood flow to this part of the brain sometimes. I'm going to take all of the patients with that kind of blood flow, and then other patients with other kinds of blood flow, and then I'm going to do some type of memory test in a double-blind trial to see if lower blood flow is actually associated, all else equal, with lower memory. You can't just say there's less blood flow here, therefore, and because I know the parts of the brain generally do this, like, oh, I'm just going to go ahead and assume that if I can increase the blood flow, it'll fix the problem. That's not always true. That's never necessarily true. Well, I shouldn't say it's never. It's not necessarily true. It doesn't necessarily follow. You have to investigate that. That's a starting point for research.
boards and or the bar, getting ready to take the bar, and wanted to function better. And I had previously seen Kendall, who had post-COVID anxiety, and Chloe, who had a traumatic brain injury. She was in a bad car accident, and they got benefit from my work. So I saw Kim, and it just blew up because the little clip they played was her and I talking, showing her brain with lower activity in the front part, which is not good for her.
And once you find that there's this low activity, what is your recommendation in those scenarios?
Is fix it, is improve it. And so you can do it with medicine, you can do it with supplements, you could put them in a hyperbaric chamber and see if that does it. There's neurofeedback that you can do. There are also some stimulating treatments, things like TMS. So my job is to give her the options. I think we went with stimulating supplements and see how that works. And the cool thing is you can look at it again and go, well, is that working?
If you were to interview Kim and hear all these struggles that she's having taking the bar, issues with impulse control, would you have been able to come to that same diagnosis without the imaging?
Well, I would have been able to guess at it, but I wouldn't be able to know.
Well, there's a difference between...
Oh, so patient reporting, self-reporting for patients is essential then, not just optional. It sounds kind of essential then. Okay.
guessing and asking validated questionnaires.
So I had this discussion actually with the head of the National Institute of Drug Abuse. And she goes, but the brain has language. And it's like, no, you can't see low blood flow from just talking to somebody. That's
see
just
low
an
blood flow
insane
on patients.
position in my mind. It's like, well, how would you really know if you didn't look? And it's like, oh, well, I can tell because you had these symptoms. It's like, no, you can't. It's like, that's a leap in logic that just isn't correct. Because that's what most psychiatrists believe now. Oh, you have 6 of these 9 symptoms. You're depressed. That means your limbic brain is too active. I'm going to give you something to calm it down. Well, SSRIs wouldn't have black box warnings if it worked like that all the time. And it's just not my experience, even a little bit, is I can get 100 people that are depressed, and we're going to find 7 or 8 different patterns. In fact, I wrote a book on ADD, Healing ADD, See and Heal the 7 Types. I'm like, it's not one thing. Why is Ritalin controversial when it can take the right kids from C's, D's, and F's?
100 different people, 7 or 8 different brain patterns for depression. Is this compared against a control group at all? Because now he just made it sound like it's basically fucking reading tea leaves, or it's like fucking random. Like he just said that the SSRIs don't work all the time, but there are 7 or 8 different, I don't know, maybe there's a treatment modality for every, I don't know.
A's and B's, but make other kids suicidal.
Right? I don't know why I'm saying I don't know. I know he does. It's all quackery bullshit, but...
I mean, why is Ritalin controversial? Because it works dramatically well for some kids, and it disrupts other kids or adults.
You said that based on your questionnaire, you would still have questions that needed to be answered that you could get answered by this imaging protocol. Does your treatment then change?
79% of the time. I published. the study on this, where we took 107 cases, gave them to board-certified psychiatrists, took out the imaging, and we went, here's the history, here's the mental status exam, here are the answers to the questionnaires. What's the diagnosis and what would you do? And then we added imaging, and we go, in what percentage would it change? 8 times out of 10.
From their protocol, it changed their guidance?
Changed their guidance.
How? Give examples. I want to hear examples of that.
Is the imaging so controversial? Like, even when you came in, you said that people hate you now. Is it because of the imaging?
Well, some people love me, but
you have a lot of people who love you.
I have a lot of people who love me. But if I'm right, and I think I am,
of course,
that means 40,000 psychiatrists and actually hundreds of thousands, family medicine doctors, nurse practitioners, OBGYN doctors, internists, right? Everybody and their mother prescribes psychiatric drugs. 85% of psychiatric drugs are prescribed by non-psychiatric physicians, are flying blind. And when you say that, they don't say thank you to that. Damn. It's like, we need a new paradigm, and we need a paradigm based on imaging, because what imaging will do is completely reshape how we diagnose and treat people.
Why don't, if we're flying blind, why don't we include this imaging? Why doesn't every family medicine doctor, why does the American Psychiatric Association, American Academy of Neurology, why are they against this imaging?
Well, not everybody's against imaging. That's really important.
That's not what he's... Not like, oh God, he's even doing like the low IQ thing. Like, why is it that all of these larger institutions are opposed to your treatment modalities or the way that you want to approach treatment? And he's like, well, not everybody is. Well, clearly the majority isn't in favor of it. Otherwise, you wouldn't be here speaking out against the majority. That's clearly not what he was saying. Why give such a stupid fucking response?
Because,
Society for Nuclear Energy.
Did you ever read Thomas Kuhn's book, The Structure of Scientific Revolution? It's such a good book. It was written in 1962. Because when I first started imaging, there was all-day seminars at the American Psychiatric Association on brain SPECT imaging in child and adolescent psychiatry. All-day seminars. And I went, I loved it. In 1993, I taught in it. And then they go, oh, you shouldn't use this. We're like, well, why? Remember I told you my dad, bullshit, no? I'm like, bullshit, no. Why? I'm a better doctor because I use this. Yeah. And it doesn't fit the paradigm. It does not fit the DSM paradigm. Is we make diagnoses based on symptom clusters with no biological data. This is the paradigm.
But if it works, why wouldn't they want it?
Okay, so Kuhn talks about 6 stages of scientific revolution. Normal science.
Also, I'm sorry, massive, not to say that this guy's book is bad or whatever, I don't know anything about this book, but like, you're 2 doctors. You're doctors, okay? That's a lot of training. Bro, doctor training and all the shit that they have to go through to finally become like a licensed physician to go and work at a fucking hospital. There's so much you're gonna go to. I expect like a real ass conversation diving into some very like difficult subject matter that I as a layman probably wouldn't be able to interpret. So I'm expecting like you to go back and forth on papers, on a sophisticated understanding of like a large body of research. Not like, have you ever read a book called Scientific Revolution? You ever read this pop sci book? Imagine it's like 2 people debating fucking Israel Palestine, and one of the guys like, you ever read Guns, Germs, and Steel? You ever seen why? Hello?
You're just going along doing what everybody else does. Stage 2, somebody notices there's a problem. I prescribe Prozac. Some people get better.
Like even here, like if you're a doctor and this is the shit you've been studying your whole fucking life, why would you point to some random pop sci book or whatever, which again isn't bad. I'm not saying that all pop whatever books are bad, okay? I'm not even saying Guns, Germs, and Steel is bad or whatever. Okay? I don't know enough to say it's like a shit book or whatever. But like, wouldn't it make more sense to talk about like examples in science, examples in this specific area where this has been the case? Like, remember when everybody said that this drug or this treatment thing or whatever, this was a bad idea, and then we knew through later research it was actually a great idea. Give examples from the actual field that you're expertised in. Your expertise. So why would you cite a pop whatever book? Give me something that you learned in fucking college or while you were doing a doctor thing.
Some people want to kill themselves. Okay, we have a problem. 3, the status quo sees there's a problem, but they make small incremental changes to protect itself and the money. And so how many versions of the DSM are there? Well, there's 6 of it. Even though it's DSM-5, there was 3 and 3R. But it's the same as DSM-3. It's really not different at all. Stage 4, somebody comes up with a new paradigm. Detailed histories, imaging, natural ways to heal the brain, and an integrative or functional medicine approach. We haven't talked about that yet.
Oh, functional medicine.
Stage 5 is the most consistent of all the stages, the rejection. It's like, no, you're crazy. This is how we do it. The brain has language.
Do we do acceptance?
In science, we're trying to always come up with a validated solution to our problems. And when I read people who are smarter than me who understand this field, like the Society of Nuclear Medicine, I don't fully understand what they're talking about. I can't argue the nuances with them. I can't argue the nuances with you. But their statement as an organization that is set out to seek the best for their patients, perhaps imperfectly at times, say that this imaging is not validated enough to be used.
More. Ooh, we're ramping up the pressure. Dr. Mike's been grinding those fucking JCS videos, doing a lot of nice talk, small talk, letting the guy ramble on some bullshit, little challenges, backs off on the challenges, and then, ramping up the pressure. Okay, Mike CS, let's go.
And it's not that they're against imaging. They're just saying that the imaging is not validated or can be used repetitively across a diverse group of patients. So it's not that they're anti-looking at the brain. They're anti this specific method because they feel that it doesn't have enough evidence.
The Canadian Association of Nuclear Medicine wrote procedure guidelines on SPECT as if I wrote them. That SPECT is indicated for head trauma, for seizures, for dementia, for stroke, for addiction, for toxic exposure, for neuropsychiatric indications. So it really depends who you read, right?
Well, I'm reading the largest agencies that represent neurologists, psychiatrists. It's like me saying something fully against the American.
Like, this is like such a waste of it. It's so retarded. It's like Dr. Mike is like, the other guy's like, well, who are you citing here? And he's like, well, I'm citing the broad associations that represent collectively an entire body of research and clinical practice. Who are you citing? Well, have you ever read this book called The Scientific Revolution? or how scientific revolutions happen? It's like, come on, bro.
Academy Family Physicians without evidence to say why I'm disagreeing with them.
Well, I have 90 studies that I have published.
Oh, you have individual studies. 90 studies you've published. Nobody else has picked up on this? Nobody else is trying to make money off of this? 90 studies you published. Well, hold on.
And I have the world's largest database. And I actually don't know.
The world's largest database of what? Of your treatment modality or whatever?
What the point of us arguing about it is. I have more experience in this than anybody probably.
Oh, he's mad. You gotta pull back. You gotta pull back. Don't pressure him too much, okay? Don't ever give in to the pops.
Probably in the history of the world. And I actually don't know what the point of us arguing about it is. I have more experience in this than anybody probably in the history of the world.
Remember what I said before? Credential citation is a lack of confidence in your subject mastery. Every single time, okay? If you argue with somebody who is credentialed, you argue with somebody with a lot of experience, they don't have to cite their credentials. They'll bury you in knowledge. They will know every single thing, or enough, way more than fucking you will, right? When you watch the flat earthers, or you watch the fucking whatever people debate, they're not saying like, I'm the world's premier flat earther expert. They'll be asking you, why does light bend around a black hole, but we wouldn't expect light to fall off at long distances when the flat earth sun shines from, 100 miles away or whatever. Like, you're like, oh shit, I don't fucking know the answer to that question. And they'll have some bullshit answer, right? Anybody that has to throw up their credentials when they're getting, I would say, crushed. Mike is just asking the most gentle. Also, these are like level 0, level 1 questions. Like, oh, well, it's interesting because you stand in opposition to like the entire field of nuclear medicine, or the people that represent this. You stand in opposition to the entire American Medical Association, in opposition to these things. What do you have to say about that? Oh, so what, you're going to come at me for this now? Fucking seriously? What, you trust these fucking guy? Really, bro? You do you have any idea how many bougie patients? Kim Kardashian. Show me your doctor fucking visit with Kim Kardashian, okay? I've seen so many celebrities. Oh my God.
And if you don't look, you don't know. And some people go, oh no, we should just continue to do what we're doing, which is a disaster in our society. Mm-hmm. And I'm like, no, I don't believe that. We need to do better. Yeah. And if you don't look, you don't know.
True.
Logically, what you're saying makes sense. And I think evolution-wise, scientifically, all these organizations will agree with you that we need to move in that space. Mm-hmm. But do we have the randomized control data to be able to back these things up?
What's that mean?
Well, give me an example and I'll tell you what the research is.
Well, let me ask you a specific question. Is there randomized control data on SPECT scans and their efficacy in a specific mental health condition?
Yes.
Okay.
Which one?
Well, which one do you want to talk about?
Anyone.
Why would you just have the strong? You should just, when somebody asks you that, you should have the strongest study ready to go. Like, what is the strongest argument I can make for my field of whatever memology, right? You should just know. What do you mean, like, well, ask me one and let's go from there. Like, you should just know, especially because this is the shit that you're trying to promote. Like, this is your life's stuff. You have a company for this. Like, you should just be ready to go, bro. Wow, Max, thanks for $10.
A specific mental health condition.
Yes.
Which one?
Well, which one do you want to talk about?
Anyone.
I mean, if you go on PubMed.
Well, can you name one right now?
Today.
Oh, he hit him up with the name of study. Ah! Uh-oh.
You're the leading expert, so I'm a family medicine.
He is the leading expert. That's true. It's not enough to say it. You should know it. That's the point of being an expert. It's not to say that you're an expert. It's to be an expert.
Like
I don't know,
distinguishing, one of the most important things to do is distinguishing post-traumatic stress disorder from traumatic brain injury. And because they often present with similar symptoms, but the
Distinguishing traumatic brain injury from post-traumatic stress disorder. Distinguishing the two? I feel like one can, aren't we talking about like different things kind of? Like TBI is like is traumatic brain injury a physical trauma? Like it has to be, or could you call anything a TBI? And then PTSD is a psychiatric condition, no? Or a psychological condition? Would you say psych condition? Mental health condition?
treatments are actually opposed to each other. PTSD, generally, you want to calm the brain down. Traumatic brain injury, you have to repair and stimulate it. I published 2 studies on 21,000 people showing we can separate these groups with high levels of accuracy. In 2016, Discover Magazine listed our research as one of the top 100 stories in science. We could also talk about Alzheimer's disease.
But that's not a randomized controlled study.
I'm sorry?
That's not a randomized controlled study.
We're talking imaging.
Yeah.
What do you mean? We're talking imaging. We don't need RCTs. Where we're going, we don't need good research. We just need the brain machines.
This is not a pharmaceutical intervention where we're going to do
Well, the goal of doing the
Oh, so you have no research. What he meant to say, what he's in the process of saying, Mike's cutting him off, what he's in the process of, we have no research. We don't have fuck all, is what he's about to say. This is imaging. How can you do randomized control trials on imaging?
imaging is to create more customizable treatments, as you said. And if you have customizable treatments, your outcomes should be better. That's the randomized controlled study.
And our outcomes are better. We published a study.
That's not
Better than what? How do you know they're better? If you don't have a control group, better than what?
Question I'm asking. Randomized control data is really important. Wouldn't you say to develop a causal relationship?
Does he not know what any of this even means? Listen, I gave them the thing and they got better. Of course it's the thing, right? The silliness of this, is like, if I have a person with COVID, I can say basically anything cures COVID as long as they don't die, because no matter what I give them, they will get better eventually, right? If they don't die. So you're not really saying anything of substance, right? If I give a person water cures COVID because I gave them water and eventually their COVID got better. If I give them orange juice and eventually they get better, I can say orange juice cures COVID. This is not a meaningful statement. You haven't causally demonstrated that your treatment is more efficacious than whatever the standard of care is, or literally a fucking nothing, right? As long as they get better eventually, you're not making a meaningful statement.
Randomized control data is really important. Wouldn't you say to develop a causal relationship?
I'm sorry. Say this again.
Like, randomized control data is very important to establish a causal relationship, because you want to make sure that your treatment is causing an improvement in whatever condition you're studying that's better than placebo at least, and better than whatever the standard of care is, right? So if you're saying that you help a person get over something, you need to be able to demonstrate that your particular intervention, the thing that you're doing, is what is actually causing them to get better over placebo, over nothing. Or for some trials, you don't use placebo. I think you just use the standard of care. Like, I think for vaccines, it's considered, if you have a standard of care that is just shown to work, then you don't do a control group where they have a placebo, because it's considered unethical, right? Like, if you have some disease, that this thing is significantly better than placebo, then you'll just compare to the standard of care group, because giving them placebos on a thing when you can help them is considered unethical to do. But the fact that this guy has no knowledge of like any of this, and he owns a company? What does he do? He says he's published 90 studies and he doesn't know the significance of a randomized control trial? Or what? Like, that's so crazy to me. What have you been doing your whole life?
Randomized control trials are very important to
Why does Mike have to explain this?
creation, causal interventions. To say that this isn't just a correlation, this is a causative pathway. You need the randomized control data to remove outliers, to create a generalized group.
Why do we have to explain any of this? This is crazy.
Have them double blinded to not know which one's getting intervention, which one's not. Because it's great that you're helping people. And I am so for that you're helping people. And I want more.
Okay, dude, he's got to have been watching some cop and circuit. Now he's pulling back, right? He was putting on pressure. Now he's got to reestablish the rapport, right? Okay. I'm not asking if he kills your mom, but listen, okay. Like, so where'd you go to school? Like, you were captain of football. You got to pull back, butter him up a little bit.
Now I'm trying to think, as a family medicine doctor, how can we generalize what you're doing so that I can do it too? But in order for me to do it, I need to know it works from a randomized controlled study. Why don't we have that?
So just design it for me, because you're going to randomize.
How does he have? For a brain imaging thing, what do you mean? Design it. What would it? I think it would go to what I said earlier. First of all, we have to make sure that the behaviors themselves are even like reducible to these brain patterns, right? So like if you have increased blood flow or decreased blood flow, can we even link that to it? So first you even have to establish that link, which I don't even know if that exists. It might. I have no idea. And then from there, it would be whatever intervention that you have, right? So if it's doing a brain scan and then treating from there, you would have to have a patient group, some people that have the disease or whatever, and then you would have to demonstrate like some people have this treatment, other people have that treatment, and then you see if yours does better. Like, I don't understand the...
You got imaging, you didn't, so automatically it's not blinded.
Well, you can get...
You can, but the people that are reviewing the research or the patient outcomes, or the, I mean, I'm pretty sure you could design a thing some way to show false images to it. Well, I don't know how you do that, but okay, hold on.
Sham imaging.
Sham imaging, is that what he said?
Okay. It's not blinded.
Well, you can get sham imaging.
Okay, yeah. I'm sure you might.
Okay.
You've been doing this since 1991, so I'm trying...
Yeah, true, yeah. Shouldn't you have the answers to this?
Trying to look at you as the expert. Like,
Because, like, let's assume that you couldn't do RCTs on this, right? Let's assume that you couldn't. He would know that, but then he would just immediately give you the answer, right? If you were like a parachute manufacturer and you wanted to determine if parachutes were better than you couldn't... Somebody's like, well, have you done a double-blind study on parachute jumping or whatever? And it's like, well, generally you would compare it versus like a placebo, but like you can't test placebo parachutes because the person would die every single time. It would be highly unethical to do so, right? You would have an answer immediately for why you can't do what would be expected of you if you were approaching this in good faith.
Do you not feel that it's an issue that there is no randomized control data? Like, you're asking me to design the trial right now.
We have data that goes, you get better and you don't. So what's the difference?
Who gets better and who doesn't?
Depression of people who got better and those who didn't.
Where are you sourcing those patients from?
These are retrospectives.
Well, from our clinics.
So all your patients are getting the spec. You're not separating into groups of, here we're treating patients who didn't get spec.
Well, no, not everybody gets scanned at our clinics.
But for the research.
But then you can't say people who choose not to, because now you're having a huge selection criterion here. We just went from a double-blind study to a zero-blind study.
You're pointing out, like, you have this study that shows 84% of your patients improved. But we're not comparing them against a group of people who didn't get spec.
No, but nobody that I know of has outcomes like that.
But do you think...
Wait, what?
Like, you have this study that shows 84% of your patients improved. But we're not comparing them against a group of people who didn't get spec.
No, but nobody that I know of has outcomes like that.
Do you think that's enough for me to start...
What the fuck? King. This guy's a king. The problem with Dr. Mike is Dr. Mike's getting brutally fucking mogged here by this guy's ability to just know the answer. And Dr. Mike is on the beta cucklord position of like, I need these double blinds. I don't know anything. I can't. And this guy's like, my patients, they all get better. Or I discharge them into the fucking cemetery. I don't give a fuck. Okay, I know my shit works because I do. You're gonna what? Let some statistician decide whether or not, some p-value decide whether or not your treatment is based or not? Seriously? Fucking loser?
Doing spec in my clinic?
I think if you started doing SPECT in your clinic, it would revolutionize your practice.
And you're saying that as someone who's passionate about it, or that there's proof of that?
I'm saying it as someone who has taught people around the world to do imaging, and they become passionate about it.
Yeah, so we talked about the patient selection of it all earlier. How if you have patients who are highly motivated, it can bias your outcomes. Like, we do journal club in my family medicine residency. And part of it is there a bias from the patients? Is there a selection bias of who you're selecting? And when you have your clinic, people who love you, is there a chance that you could be introducing bias by only looking at the people who love you, support you, and want your treatment?
Like, how is this the first time this guy's ever had to answer a difficult question in his life about defending his thing? I don't understand how you've never thought about these questions before. You've never pondered these questions. Like, by the way, and listen, I love Dr. Mike and I appreciate and respect what he's trying to do, but like, we're an hour and 10 minutes into this interview. This is where a good interview with two good faith actors, this is where it should have started. This should have been the start. We're like 5 minutes in. These are the questions we're asking. I don't know, man.
Well, I mean, we do have a more motivated group, for sure.
Okay, well, that biases everything you're doing. What? But he thinks this is a good thing? He's like, well, they're motivated to get better. Like,
we have a group. Yeah, I think it's a more motivated group for sure.
And what outcome do you think that has on the outcomes that you study?
Why is Mike walking him through? He's like walking him through the basics of like selection bias and how different groups of people that are taken from unequal, sectors of society or unequal admission processes or whatever, that these groups of people might be different for some reason.
So we actually did this study this week.
Oh my
on
God.
Compliance. Because we do a formal outcome study on everybody we see. I mean, I don't know if you know many clinics that do that, but the people who are very compliant get better way.
If Mike wanted to fuck him hard right now, he'd say, you do it on every single patient? Do they all follow up? What's the what's the attrition rate on those follow-ups? Is it 100% every single, or would it be 0%? Every single patient follows up to the end? What's the drop-off? Because on every study you have attrition rates where people drop off, and you got to make sure that the people that are dropping off aren't dropping off for all the same reason that would might maybe bias your results or whatever. I don't know. He's probably got to soften up, though, because this guy's about to walk. This guy's getting triggered. This guy needs some SPECT brain imaging to calm him down.
Faster in much bigger numbers. So we ask everybody about their compliance, and compliance is just huge. I think you would agree with me.
Yeah, for sure. And it's great that you're doing the reassessment, because I feel like that's missed a lot of the time.
Well, very few clinics actually focus on outcomes. And for us, it's research, but it's also quality control.
Sure.
And if you're not compliant at all, your outcomes are not very good.
That's for sure.
That's
but
true
also
of
mental
every
health patients, or patients who have issues with their mental health. They tend to have lower compliance, not because they're bad people or saying something negative about them. They're going through something.
No, it's because their brains aren't healthy. So, I mean, yes, they're going through something, but in large
human
part
experience of their
because
depression.
their brains are not healthy. I mean, we might agree, maybe not, that if you're depressed, something's going on in the organ of how you feel, which is your brain.
Sure. And like you're such a proponent of CBT, we say depression can be a chemical imbalance. Well, CBT actually alters the chemicals in your brains, right?
Yes. That psychological treatments like EMDR or CBT, impact.
DBT, whatever alphabet soup we want to put, they all help with changing the chemical composition.
True.
But you're still advocating, at least what I'm hearing, is you're still advocating for not looking before you go about changing.
Because I don't want this to feel like a gotcha. Because what I'm trying to do is...
It doesn't feel like a gotcha. It feels like a good conversation.
I really want to learn from what you're doing. Because I want to be a better doctor. Genuinely.
So soft.
Like my goal, why I still practice medicine, is because I want to deliver the best care for my patients. And if what you're doing is great, we need to get that message out there to the world as fast as possible, because otherwise people
If what I'm doing is great,
so
what?
in order to make the generalization that everyone should get a SPECT scan before...
That's not what I said. But if I
correct me
get
then.
you to be a better doctor, just start thinking of mental health as brain health. Is this person actively working for their brain's health? You can do that in your practice. And
Without
then
SPECT
there's
scans.
going to be a day when SPECT or fMRI or quantitative EEG or PET is going to be covered by insurance, and you're going to be able to use it. But what you can do today is you can go, if we improve the health of your brain, your anxiety is going to be less.
Like, if these things, Mike's point, or I don't know if he's making that point or not, but like Mike's point is that if these things were increasing patient outcomes, it would already be covered by insurance. Like, why can't you just demonstrate that? Also, it's very weird that he just backed off SPECT and he just went with every imaging technique. I thought he was pushing his particular one, but like, we already have MRIs and stuff that are commonly used, or other types of scanning technologies. Nobody's thought to try to use these with mental illness. Nobody's ever considered that before. There's no research showing these increasing patient outcomes. Also, by the way, let's assume that Big Pharma is greedy. Let's assume that doctors and hospitals are greedy. I mean, it's not like these tests are fucking free. So even if they were greedy, they would have every incentive to push a fucking new big-ass fucking MRI, a big-ass fucking whatever X-ray scans or whatever. They would still have the incentive to do all of this as well. So it's not even like where like Big Pharma would be preventing this. Like Big Pharma and Big Hospital and Big Doctor can all make money off this shit too.
And it starts with one question. I teach all of my patients, whatever you're going to do today, is it good for your brain?
And then this like back off into, it's so crazy actually. Maybe I should start analyzing debates and everything from the perspective of like, I guess like a police interrogation or whatever, where you're just like gently applying pressure to pull some concessions and then you have to pull back. Because now he's doing this thing where he's like overgeneralizing. It's like, bro, nobody needs these like crazy, quacky, overgeneralized statements. But you're a doctor. Give me some real shit. I don't want you to sound like my plumber uncle talking about medicine. Like, I want to hear some real ass shit from you.
Brain or bad for it? Is it good for your brain or bad for it? And that will begin to spark a revolution in their life.
Jesus.
Now, if you have somebody that's not getting better, you should advocate for them to be imaged, because to continue to fly blind is not anybody's interest.
So for my patients who have such bad major depressive disorder that they can't groom themselves, they have trouble taking a shower, the solution is asking them if what they're doing is good or bad for their brain. You think that's enough motivation to help this individual?
No, it's all of it.
And then back to the generalizations again. Always back to the generalizations.
Now I feel like you're twisting my
Well, I'm trying
words
to
to
understand.
create conflict.
Please tell me how do
it's
I
like if
understand
somebody,
because you're saying the one
if
question.
somebody is that bad, you should be advocating to look at their brain, because you don't know if they're living in a mold-filled home. That
Oh my God, it's every meme, the mold. Jordan Peterson's daughter is popularizing this one now because all of Jordan Peterson, it's so crazy. Like, they don't believe in any of the actual diseases, but sometimes they will just believe in the most like exotic and esoteric diseases. And Jordan Peterson now is like apparently a victim of of mold their entire life. Also, they like to hijack or they like to jump on the backs of other like real things. So for instance, like I criticize the chronic Lyme disease shit a lot. Lyme disease is a real thing. It's a real thing, and you can have Lyme disease untreated for a long period of time. But when people talk about chronic Lyme disease, they have this weird theory that like most kids at some point in their life, get bit by a tick and they develop Lyme disease. And even when you cure it, there are forever effects that last for the rest of your entire life. You have to manage. Chronic Lyme disease is what they'll call it. There's zero evidence for this whatsoever in the medical world. There's no evidence whatsoever of a chronic Lyme disease. You can have Lyme disease for a long time. There's no evidence of that, right? What he's talking about when I just bring up the mold thing, I'm pretty sure there is strong evidence. I'm pretty sure we just know that if you live in like heavily moldy environments for a long time, especially if you're breathing in this shit or interacting with it, it's bad for you. But the Jordan Peterson, Michaela Peterson meme that they're pushing is this idea that like every house has like some secret or some amount of mold, and it's actually a massively pervasive problem. And your huge red flag for it is when people push their pet theories. This is always one of your biggest bullshit conspiracy detectors, even outside of medicine for everything else, is when their one thing actually explains so much more. It actually explains so many different things. And what we thought was ADHD, what we thought was violent behavior, what we thought was, it's actually all explained by mold, because they can never just have a thing that explains a simple thing. It also has to be some transcendental idea that actually encompasses so much more than you ever even fucking thought. And literally none of these things ever pan out, of course, but yeah.
Is damaging their brain.
Mm-hmm.
Right?
Why don't we check everyone's brains?
Everybody should be asking themselves that question. Is what I'm doing today good for my brain or bad for it? But do you spend any time as a family doctor asking
about
that
mold?
Question? No. Is this good for your brain or bad for it? Going through their habits or just teaching them to love.
I'll be honest, I don't.
For.
I don't, and I'll tell you why.
Why is because one is because you don't have the time, and two, because you don't want to go on a red herring chase. You might be doing a thing, like somebody could ask you a question, and that might not be relevant at all to the notice you presented, and then you give a thing, and it's like, that's not relevant at all either, but like it could send me down a wild fucking goose chase on a totally unrelated illness that you don't even fucking have because you're not even reporting any symptoms related to it. Like, it's a waste of time, and it's unnecessary, and it could send you the wrong direction, which is ultimately just another type of waste. Sorry, but
I don't. We don't have enough time with our patients, so that's a little bit of a cop-out. But at the same time...
Yeah, because that's a really easy question. That's like, in the 7-minute visit, you can take 30 seconds to ask them that question.
30 seconds to ask which question? There's a billion questions that you can ask about related to patient health. You think it's just one thing? Oh, is there mold? Like, even what he said earlier about getting people to remember traumatic brain injuries, and I actually believed him when he said that it's hard to get somebody to remember that. I've probably lied on that, not lied, but apparently I got knocked out when I was in first grade or something, or a kindergarten, some kickball accident. I forget this 95% of the time. I think my mom and I were talking about this 2 weeks ago. It's the only reason I remember this now. But that wouldn't surprise me if you had to ask a lot of questions. You've never had a thing where you were concussed, maybe when you were playing with some friends and mom took you in, you didn't call the ambulance or whatever, right? And that's just one particular type of question related to maybe a brain injury. There's a billion questions that you could ask about a billion things, about drug use, about exercise, about any other weird, do you feel weird things in your heart? Do you have anxiety? Do you drink? Do you blah, 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 any family history of a million fucking things?
You don't have it in your head yet. That's like, in the 7-minute visit, you can take 30 seconds to ask them that question.
You'd be surprised.
But you don't have it in your head yet because we were never taught that mental health is brain health.
I do ask that question without asking the question. This is my second point.
Symptoms?
I ask questions that don't directly ask about the brain, but ultimately point to me behaviors that they have that put their brain at risk. So I ask about smoking. I ask about alcohol. Okay. I ask about diet. I ask about intimate partner violence. I ask a PHQ-2 screening question. So while I may not be saying the question as specifically as you are, I am figuring out the mental health state of the brain. So,
but not the brain health state of the brain. See, that is the distinction. That if we get anything,
what is that distinction? Because I'm having trouble understanding that.
It's not mental health. It's brain health.
The
distinction is one is loose. Mental health, that's very loose. PHQ-9, GAD-7 stuff, or is your brain healthy?
Like, if I had to guess, because I feel like this is, I'm sorry, I'm just going to say this stronger until a neurology person corrects me. The self-reported symptoms are probably going to be a more reliable indicator of something wrong than the quote-unquote current brain state. Unless you've imaged this person several times in their life, and you know which brain states or what blood flow, whatever, is correlated with what behaviors, you're not gonna have any idea if you measure a person's brain to be able to just say like, oh shit, I'm fucking Neuralink and I know exactly what's wrong with you now. Like, if you could choose every time between doing a brain scan versus like a patient self-report, my guess is going to be the patient self-report 98% of the time or 99% of the time is going to be a more indicative, maybe even more than that. It's going to be more indicative of a problem that the patient is experiencing than any type of fucking brain scan. Especially because why does nobody do these? If this is so indicative of some kind of brain health issue, if this could be predictive of depression or anxiety or anything else, why does nobody ever order these types of imaging to be done? Why do we have no research on it? Like nobody cares. Big X-ray is not trying to push their machines. Big MRI is not trying to push their machines more.
And if you want to keep your brain healthy or rescue it, you have to prevent or treat the 11 major risk factors. So I told you, so the big 3 ways I want to transform psychiatry: imaging, if you don't look, you really don't know; natural ways to heal the brain, and an integrative or functional medicine model. And that's why our model not only works to decrease depression, it helps to prevent Alzheimer's disease. And I think you prevent Alzheimer's disease by preventing or treating these 11 risk factors. And the acronym I talk about is Bright Minds. Like B is for blood flow. Low blood flow is the number 1 brain imaging predictor of Alzheimer's disease. S is sleep. And then all sorts of things in between.
So you said that when a patient is that severely depressed, they should get a SPECT scan. Is that true for all patients?
That are that severely depressed?
That they have trouble showering, getting up out of bed?
Absolutely. Because how do you know why they're that way?
Well, the issue that I believe...
No, answer the question. How do you know what is actually going on in that person's brain without looking?
By asking them questions, by doing
That's complete crap, Mike. It's complete crap that you know.
See, like, I'm sorry. Now, for you to have the right to say that, because when he says that's complete crap, he's attacking the entire field of research and clinical practice related to how we treat mental illness, which is not perfect, by the way. Mental illness is difficult. We do have arguably a crisis in how we treat it. There arguably might be an over-reliance on pharmaceuticals, right? I think these are all fine statements. I don't think, my guess is people in the field probably don't even necessarily disagree with that. Or psychiatrists or psychologists or therapists wish they had other treatment modalities that had a high rate of efficacy or whatever. But the reality is that like all of it is fucking hard. People will say like, well, a simple SSRI isn't going to fix your problems. Yeah, simple fucking therapy doesn't fix your fucking problems either. Cock and ball torture or dick and ball torture, CBT or DBT, also doesn't necessarily fucking fix your problems. It's not like a guy's like, oh, thank God, I've got the patient with borderline today. Good thing we discovered DBT. Now I can fucking, with a 99% success rate, fix this motherfucker. Like, a lot of these things are barely better than placebo sometimes. It's hard. Mental health is difficult. But like, this guy doesn't have the right to have this much righteous indignation or fury, because he hasn't fucking even, he seems like, from the way he's talking, he doesn't even know how to begin to understand how to prove the efficacy of the things he's talking about, let alone actually have the proof.
What's going on in that person's brain? You're guessing. Now, maybe it's an educated guess, but don't tell me you know, because you completely don't.
Well, here's my defense of why I feel like it's better than just a slightly educated guess. Because when you look at randomized controlled trials for people who get either therapy or antidepressants or sometimes both, we see the improvements. So while it looks on paper like a guess, we see the outcomes hold up, validated across.
I've been doing this for 45 years. You're guessing. And
But
maybe you can point to some studies.
Also, see, notice how, dude. Oh my God, I'm so sympathetic to Mike, right? When you have to do this, when you're dealing with some fucking retard, conservative fuckwad, and he's like going in on you, and I have to be so fucking careful not to say anything that he could even perceive as an insult. Like, this guy he's treating Mike as a fake doctor, right? Like, you don't know what the fuck you're talking about, you fucking piece of shit. You don't know fucking anything. Like, he's going off on him, and Mike has to be so careful not to upset this fragile fuck.
They'd say, oh.
Are you saying there's no studies that show therapy, CBT has...
You're completely mixing lots of different concepts. This patient, you don't know because you didn't look. Now, are there studies on big populations? And most of the severely depressed, like you're talking about, there's not one single thing that works for them. They need a common...
Notice the backing up to like this general shit that, by the way, I doubt Dr. Mike even disagrees with. Wow, a person with a severe type of illness doesn't just need a single intervention. Like, this is probably true of almost any severe, especially chronic illness, where there's not like a single intervention. Like, oh, you got bad heart issues, like go run on a treadmill. This is probably a multi-level approach to almost any chronic condition or any severe condition, would be my guess.
Nation of things.
I didn't say that they wouldn't. I just said that there could be a combination.
But you don't know what's causing it.
And I think imaging holds such a key here, which is why I'm trying to figure out how to get it to the masses on a level that is scalable. So I'm trying to figure out how we get there. How do we get SPECT across the APA, the AAN? How do we get everyone?
Well, I think the Canadian model, I mean, it's covered by insurance in Canada. I think that is a really great model, that there's a lot of research that when you really understand it and put it together,
you can't cite any of it.
Imaging plus clinical evaluation, we have better outcomes. And that's why they wrote the paper. I didn't write it. I'm not an author on it.
But we don't have that. I just asked you.
We do have imaging and head trauma, imaging and depression,
but I'm not
imaging
asking
and
for
ADD.
imaging. In order to universally recommend a treatment,
it has to be
it's not a treatment, it's an assessment.
I know, the assessment leading to the treatment, which changes ultimately the treatment because it's customizable. In order to verify this, we need to be able to test it with a randomized, double-blinded, controlled study. And in 30 plus years of doing this, you're okay with not one study being done?
Ooh. Oh, that's a brutal one. Kind of calling him a quack there. God damn. Oof.
So I've published a lot. Like I published on
another
health
general.
I published on,
General.
Here's the pattern.
General.
Here's the pattern after treatment. I haven't done a study where, okay, everybody gets scanned, but we only use the scans in half the people and see.
So you've done a lot of studies, but you've conveniently avoided what would be the most important landmark, groundbreaking study that would demonstrate the efficacy of every single thing you're talking about. Like this would, you motherfucker. Like that would literally be the most important thing to get everybody on board with you. Why would you avoid that one study that would be the most important thing you could possibly do?
If that's the study you're
Well, let me
thinking
ask it
about.
to you in a different way that takes us out of the equation. If a pharmaceutical company came out and said, we have this medication, it works, we never tested it against any other placebo, no randomized controlled data, but everyone who takes it loves it, would you buy into that pharmaceutical?
No.
Or would you say, I need to see the data?
You always have to see the data.
Well,
which
where is the
why-
data?
Where's the data? My patient outcomes.
15,000 abstracts on PubMed.gov today.
But again, we're talking about the need for the randomized controlled data to be able to take bias out of the equation. You said you have a more motivated patient population.
say that.
These are all issues that can make
Selection
actual
bias.
specs not helpful for people.
Yep.
And perhaps a spending of money that is not valuable given how constricted our healthcare spending is already, or needs to be.
Oh, hold on.
And perhaps a spending of money that is not valuable given how
Oh, see that hand shaking? He's losing it. He knows he's losing it.
constricted our healthcare spending is already, or needs to be.
So you're arguing we should just continue to fly blind?
No, I argue.
He said that Dr. Mike was being fat. He did the thing. Oh, so I think we should get some research. Oh, so we don't have the perfect fucking thing? So you think we should just fucking murder our fucking patients? What do you want me to say, Mike? You want me to tell them to fucking rope? Should they buy a rope made from Pfizer and kill themselves with that? Or should they buy some razor blades manufactured by Eli Lilly and slit their wrist with that? Which one, Mike? Tell me, Mike.
But see, do you think I am advocating for flying blind? Can I tell you what I'm advocating for? Then you tell me if you agree with my notion. I think we should test spec to see if we can improve and no longer fly blind. And if it's not spec, perhaps it's something else.
Oh,
You don't think that's
something besides what I've spent the last 40 years of my life of quackery on? Are you fucking serious?
Reasonable of me to say that?
No.
No, I think more studies.
One study. One study. There's. Oh, he's so mad.
I think that would only help.
Yeah, I agree too. And I'm curious, why do you think they haven't been done?
The most important study.
I don't know. The first study that was presented in 1992 with the American Psychiatric Association
Yeah.
is they took 100
We could not find any peer-reviewed study or APA abstract supporting the claim that's.
bipolar teenagers.
Okay.
50 of them were scanned on the day of admission. 50 of them were never scanned. They looked at the average length of stay. For the kids who were never scanned, it was 44 days. Now, this was when you could actually keep people in psychiatric hospitals.
Wait, so this would be a good type of study. This might only be single blind, or I guess it depends on how you evaluate the research or whatever. But like, so this would be, so he does know about that. Wait, why did it take him so long to say this? Although it sounds like, I don't know if he had to take a while to think it up because it's fake, or if he's just misciting something, but okay.
Of stay. For the kids who were never scanned, it was 44 days. Now, this was when you could
Also scanned with what?
actually keep people in.
Well, but also you have to be careful with retrospective. So when we say prospective study, the study is designed before we begin anything, intake or whatever. We're designing a study so that we can see, is this better than this? Okay, before we do anything. This is a prospective study. Okay, looking forward. Maybe my question is going to be, does taking Dragon, I don't know, before 5 minutes help you win a League of Legends game? I don't even know if Drake is still in the fucking game or whatever, right? If you do this thing in a video game, does it help you win? Okay, that's a perspective study. Then you get like 1,000 people and then you push some of them, or maybe more specifically be just pushing somebody to get Drake before 5 minutes, does that helps, right? So you prospectively, you design the study, you get some 20 people, 100 people, 500 people, whatever, and then you separate some of them into some groups, some into other groups, you get however you design it, and then at the end of this study, as you're tracking all of your outcomes, you look and hopefully you can compare to the people that got some advice versus the people that didn't get any advice, and then everybody's comparing the data. Okay, was it a good suggestion or not? A prospective study is nice because in an ideal world, you can design everything perfectly to account for controls or other variables, and you have your thing set up so that you want to establish causality. At the end of the day, that's what you're trying to do. You're trying to establish causality. Does this recommendation or variable, does it change this other thing, this outcome? A retrospective study, now for something you can only do retrospectives, you have to look at a bunch of data that already exists, and then you have to kind of go back and see if you could figure out what's making the thing happen. But retrospectives can be different because there might be a whole bunch of filters or criteria that's difficult for you to figure out, maybe maybe it only worked for some other reason. So let's say I want to do that same retrospective study. I go, okay, well, of all the people that took Drake before 5 minutes, I noticed that like 92% of them won their games. And it's like, okay, well, clearly taking Drake early or giving the advice to take Drake early, that actually is something that really helps. But maybe if you go back and you dig even more into these groups, maybe you find out like, oh, actually it's just always the better team or the better jungler that always took Drake. And actually having the better jungler was the more determinative factor in those games than just taking Drake early. Taking Drake was the byproduct of some other variable, some other confounder or whatever, right? Sometimes you have to do retrospectives because there's not like an ethical way to design a perspective study. So for things like economics, sometimes for huge, like they call them natural experiments, like a bunch of immigrants come in or whatever, and you try to measure it. Like you can't just flood an area with a ton of people and figure it out. But sometimes it's a thing that's interesting too is with some retrospective studies, sometimes you can develop like very clever or creative solutions to figuring out, how you could control for things, but it depends on the study. I'm trying to think. They had a really clever control it was the big abortion study. It was a really clever way to filter some people out. I don't remember what it was though, but I remember it was really clever and really cute for like, cause you were trying to get it was like how many people that go to Planned Parenthood and get an abortion or whatever are happier or not happy or something. And they were like, well, the types of people that get abortions might be doing it a different whatever. But he had a way, he was like, oh, well, we only took the people who, I wish I could remember what it was, but it was a very clever way. They used like a cutoff for admission or something, and it was a very clever way. Like, oh, that would filter out all of those people that came in too late or whatever, or came in too early or some bullshit, which I thought was cute. I wish I could remember this better, but yeah, I don't know why everybody should know that. These guys should know this. Sorry, this is retarded as fuck.
Average length of stay. For the kids who were never scanned, it was 44 days. Now, this was when you could actually keep people in psychiatric hospitals. For the kids who were scanned, it was 15 days. It was an average cost savings of $15,000 per hospital stay. Is that the kind of study you're thinking about?
No, but it's getting there. That's a great preliminary piece of research that I think we can build upon, because I think we would agree that there's a hierarchy of evidence for recommendation, for deciding between causation and correlation. You agree with that?
Yeah.
So to me, unless we have that randomization where we take two groups, ideally match them as best as we can, randomize them so they don't know what they're getting, blind them, test the outcomes based on the treatments being more customizable in the SPECT category. And then if we see this drastic improvement, everyone changes their mind. AAN, APA is recommending it. We're all getting it done.
Yeah, see, that would be great if that happened.
You don't want to make a push for that on this podcast?
Nah.
Not sure this podcast is going to get us to where we need to go.
When?
Oh, and I'm so curious what's going on in Dr. Mike's brain, because he's been so fucking gentle. He has been so fucking gentle with this guy, and he's still ass blasted. He's still ass blasted over this. Oh my God.
That would surprise me.
But this is so valuable. I feel like SPEC can help so many people based on the way you're presenting it.
I think it can too.
But so if we present randomized controlled data to the AAN, APA, we publish it in the Lancet together, let's say, we can change the practice in the United States. Isn't that something you would want?
Absolutely.
So what's stopping us from doing it?
I'm all for it.
Okay, at least you're for it. That's really exciting. Because when we think about people who are critics of SPECT, I want to prove them wrong, right? Because I want to help people and I'm on your side and I want to figure out how to get this done correctly. But if we're trying to do scientific research, it shouldn't be done in a way where Secretary Kennedy said, we're going to prove that this causes this. Scientific research starts with asking a hypothetical, asking a question, creating a hypothesis, disproving yourself, proving the null hypothesis, not just agreeing with yourself or seeking to agree with yourself. Do you agree with that?
And I was thinking,
you want to set out to disprove yourself if you're doing research, because ultimately, if you can't disprove yourself, that makes your information stronger. And look, there are some
he's talking about like the thing that you would learn on day zero. Like, I feel like you would read this in the introduction to a fucking stats class or introduction to some research. It's like, oh, like a lot of research revolves around having a null hypothesis and then establishing with a level of statistical significance, some deviation that where your range of things or whatever is outside of the null hypothesis. Like rejecting the null is doing research against a particular established point, and this is like would you say the foundation of literally all scientific research? Maybe like this is one of the cornerstones of scientific research, like one of the most basic of the basic of the basic of the basic. Like every intro to anything class outside, like even in like economics and biology, and like my guess is every single science class you probably take in school, the teacher will probably at some point say the phrase, I didn't go to college. My guess is every single college, they're going to say at some point, rejecting the null hypothesis, or rejection of the null hypothesis. Or probably every single teacher in every single class, where every single intro science class is going to say this at some point. I have no idea how this is such a confusing concept to this guy.
Instances where correlation can be strong enough, where you actually don't need a randomized controlled trial. Because with
how do you do a randomized controlled trial on you have Alzheimer's or you don't? I mean, they have autopsy confirmed data that Alzheimer's disease, which has been described in the literature for 35 years. So you need better data than that to say SPECT can help in the diagnosis of Alzheimer's disease.
It's not in the diagnosis, it's in the treatment. And differentiate itself from other
standard of care as exists today.
Exactly.
For it to be found valuable and widespread recommendation.
And I would argue for...
Because SPECT is expensive. SPECT has radiation.
Ooh. Side effects.
Fuel
cost.
Misdiagnosis.
Time. Misdiagnoses. Wild
so
goose chases.
I also don't want to overdo it with SPECT, so I'm trying to find the reasonable middle ground.
Oh, yeah.
Is that correct me if I disagree with me.
He pulled the whatever. Okay. He pulled the wait, fuck, I'm trying to find this.
Oh, I don't want to watch any more of this.
You're arguing for the status quo until someone can show you a randomized controlled trial for a specific diagnosis.
Yes! He did it! Where's my applause? Correct. You just described all scientific research in medicine. It's standard of care until you have a good study to prove that your thing is superior to standard of care. Yes, that is all. I'm pretty sure that's literally all scientific research in the field of medicine. Correct. Yes.
Although I gave you the one with bipolar disorder. Yeah, I'm just thinking flying blind's not the answer.
I agree. I don't think we disagree.
And you didn't bring this up, and you don't know. The American Psychiatric Association last year named me a thought leader. And
oh my God! He's a thought leader. Fucking, I just changed my mind. Look at him. Now Mike is struggling. Mike just realized how completely and utterly fucked he is. He's like, oh shit, I didn't know this was a fucking a thought leader. He's a fucking thought leader. He's like, fucking terminate the podcast, cut the rest. I didn't know he's a fucking thought leader. We've got even more credentials to wheel out. Holy shit. Next, he's going to be on the fucking, when I did PKA, all the subreddits said I was a top 5% episode. By the way, have you had a top 5%er on fucking PKA? By the way, when it's on Joe Rogan, our podcast episode lasted over 4 hours. That's an hour longer than the average Joe Rogan podcast episode. Jesus Christ.
I'm not attacking you here. I'm not anti your work. I'm trying to figure out how to get your work to more people. We're on the same team, helping patients.
Doesn't feel like
and
it.
Hopefully bringing psychiatry into the 21st century rather than making diagnoses just based on symptoms.
I agree.
And I think
I don't think
I'm
you
just
are.
trying to do it without doing it prematurely.
No.
Because with any medical intervention, there could be drawbacks.
I don't think we did it prematurely. I think,
but you don't have one randomized controlled trial.
So?
Well, we're not thinking about it in exactly the same way.
In scientific
1992, if I get a scan, on the day of admission, it cuts hospital days 67%.
Like every single hospital would be jumping at the ability to do this. I bet they would even make more fucking money. It's not like there's a shortage of sick people in the United States. It's not like, oh fuck, hospitals like, if we have this new treatment thing, fuck, we're gonna run out of sick people. We're not gonna be able to make any money. All the sick people will be cured. Our doctors are gonna be laid off because for lack of work, there's nothing to do. The ERs, the emergency care, all of it's empty.
That's pretty exciting. And what I saw as a clinician is it changed what I did 8 times out of 10. Not only did it increase compliance and decrease stigma, it made me more effective because I had a roadmap.
I think that's great. But again, how do we get that out there? Because I'll give you an example.
Just trust me. Trust me,
for
bro.
For patients who are over the age of 40, I can do the ASCVD risk score, which is their 10-year risk score of having a stroke or heart attack. Now I plug in some numbers into this calculator and I get a percentage. Based off this percentage, I can decide course of action for this patient. And the reason why I'm comfortable using this core calculator is because it's validated across a diverse patient population, randomized controlled studies done on it, seeing what the actual outcomes are from doing this risk score calculator, as well as the interventions that follow. There are some people who make their own risk score calculators in the cardiovascular world, and they choose their own numbers to plug into their calculator. Here's why I don't agree with it. because it's not validated across a diverse group of patients. Do you see why I don't like their calculator as opposed to the 10-year ASCVD calculator? But some of them will come and show that their calculator helps 84% of their patients. Now, using their anecdote of helping their patients, should I then just throw away my other calculator and say, patients, I'm going to use this new calculator now because this person said this about their clinic?
Do the thing again where you say, oh, so you just want to stay with the old shit and watch people die. Oh, you just want to fly blind. Do that one again. I love that one. Do that one again.
Or should there be a level of skepticism, like your father said, and said, BS, no, let's test it.
Like your father even incorporates his fucking dad's fucking quote. Dr. Mike is a master. Ah!
Or should we just accept it?
I think you should test it, which is why we do outcomes on all of our patients. Now, is
You know
that
that's
going to
not a good
randomize? Is that going to go with your patients? No, but your patients will be better if you added imaging.
But you can't say that.
You can't say that
at all. Or,
Oh my God! I just want to talk about my book, and now he's gone. I just want to talk about my book, please. Please get me out of here. He's so fucking mad. Oh.
no, but your patients will be better if you added imaging.
But you
but
can't
are
say
we
that.
going to talk about the book at all? Or
Well, I mean, this is a premise of your book, no?
imaging is not the premise
Spec
of my book.
is not in your book?
It's in the book, but it's not
There's
the premise
images
of
of spec
the
in the
book.
book.
We're not going to talk about the book.
What do you mean? We talked about pain. We talked about the cycle of pain, how your brain has this blueprint that it starts cycling between that we're on board with. We talked about Dr. Sarno's work.
Oh my
Do you feel like
God, he's actually triggered. Mike should offer to image his brain right now. Mike should say, do I need a blood scan or a blood flow scan right now? Do I need to image your brain to see that you are insanely fucking ass blasted right now? Do you think I need scientific imaging to tell me that you are incredibly uncomfortable? Do you think it's fair for me to say that without even putting you in a blood pressure machine, I could probably say that your blood pressure is higher than it would be otherwise? Do you think I can make that prediction just based on, you're not even really self-reporting, just on my physical observation of you? I don't even know what would be a physical observation. It would just be a seeing observation? I don't know if doctors consider it physical. They don't have to touch them.
Being unfair? If you think so, please tell me.
Yes,
How so?
because you're like going on the same thing over and over again. It doesn't feel fun or fair. But I love talking about our work, and it's interesting to me. Often I've been criticized, and very few people go, so you've seen more scans than anyone in the history of the world. What have you learned?
Oh my God, bro. He's so mad. And he keeps bringing up just the dumbest. I kind of like Mike has like a friendly demeanor for it. So there's like, when you have a friendly demeanor and you ask people questions from a friendly perspective, it makes other people very uncomfortable and frustrated because they're getting at a thing where you both know what they're doing, but it's harder to call out. Although he's still trying to call Mike out on it by saying he's being mean. But like if you're a woman or a black person and somebody makes like a sexist or a racist joke around you and you have like a very friendly demeanor, you're like, oh, and he's laughing like, what did you mean by that? Or like, what's the funny thing about this? Can you explain it to me? Like that kind of question will make people very uncomfortable. He's like, oh, like you feel like a fucking, you can't, it's very hard to explain without actually seeming like a fucking piece of shit. So it's funny when Mike's like, well, don't you think we should have like real research for your treatment modality? He's like, I've seen lots of patients. Like, well, but that's not really good enough, right?
And as opposed to, well, you didn't do this, and you didn't do that, and you should have done this, and don't you think it'd be better if you did that? As opposed to, so what did you learn from nearly 300,000 scans?
Are you saying I said that?
No, that it just doesn't.
You
feel
didn't
like
say that.
right?
You
I mean,
don't
I
even
can only
care.
tell you my experience. It feels like,
But don't you think I should be a skeptic on behalf of my patients?
Oh, and he's so good at, this is like Dr. I wonder if him and Dr. K have ever spoken. They must have. Ooh, and he asked just like the most stinging fucking questions. Like, remember, like, shouldn't I believe in like the, no bullshit, like your dad said, right? Shouldn't I be skeptical of your treatment, like, on behalf of my patients, like a good doctor would be? Like, ooh, like, how do you, he's going to route around, well, your patient would be better off if they followed my techniques.
feels like,
But don't you think I should be a skeptic on behalf of my patients?
Oh, no, I know they debated. I know they did a thing, but I'm curious if he got like conversational techniques from Dr. Mike or whatever. Or I'm sorry, from Dr. K. That's what I meant, like having a private talk about, like, how do you do these talks responsibly, whatever.
I think you should be curious.
So am.
I so am, but you
behalf
have
of your patients.
nothing to
That
help my
if you
curiosity.
could help them have a better brain, they would have a better life. And the things like Alzheimer's disease. So I wrote a book in
yep.
2005 called Preventing Alzheimer's.
There we go.
Disease.
Broad
And
again. Broad.
Got no end of grief. It's like that's
Why?
giving people false hope. And last year, The Lancet came out with an article that said 50% of Alzheimer's is preventable. And
What were the tips that you gave in that book?
So it was bright minds. You want to keep your brain healthy or rescue it. You have to prevent or treat these.
Like, also, by the way, somebody coming out with something later is good, but it doesn't mean that you're like, when somebody says, when a study comes out, the study isn't saying like, this helps with Alzheimer's disease. What the study is saying is, this is statistically significant proof that this helps Alzheimer's disease. So if you write a book and you say, well, I think these 12 things help Alzheimer's disease, that's great, bro. That's your opinion, right? And it might even be a decently informed opinion, but we don't have the research to say it. When the Lancet comes out, and maybe it takes a while to design these trials, whatever, and then they come out later and they say, oh, well, here's research that proves it. It's like, okay, that's great. That's not them saying the same thing that you said, though. They're saying the same thing you said, but they're saying there's now statistical proof to show this. It can be demonstrated, right? That's a stronger and a more valuable statement.
11 risk factors. That if you're pre-diabetic, that's an emergency, because diabetes. If you have diabetes, you have all 11 risk factors. Just that one. So
don't do it. Don't do the type 3 diabetes.
Really creating this revolution in brain health, getting people to love and care.
Oh, a revolution in brain health. That exercise and diet and stuff is also good for your brain. Oh, revolutionary, bro. What is the revolutionary stuff they're going to start suggesting? That you need to improve your diet and you need to exercise more? Oh, revolution, bro.
For their brain. And if I was a family medicine doctor, I would be thinking as mental health as brain health.
Like the need for treating patients with prediabetes. I frequently struggle, actually, in finding motivation from my patients when they do flag on their labs having a hemoglobin A1C in that level, of saying, hey, this is when it's reversible. Because once technically, maybe there's some outliers. Once you become a diabetic, you're diabetic for life, at least in terms of your risk factors.
Yep.
Weight loss, extreme weight loss can seemingly control it, because we've seen those who have bariatric surgery not need medications anymore, even though they were diagnosed with type.
He wants to fight on that point. He's like, actually, if you scan the brain enough, if you just keep fucking scanning it, it'll go away. He doesn't like that. Not reversible? I found a way to fully reverse the worst diabetics. I can resurrect your fucking... Is it your pancreas? Or is it your liver? It's your pancreas, right? I can resurrect it from the dead.
To diabetes. But in the majority of cases, the time when it's reversible is the pre-diabetic stage. So I struggle in helping my patients get motivation there. So which of these 11 recommendations in the Alzheimer's book do you think that we're lacking in the primary care space, so we can encourage doctors to do it?
So much of these bad things that happen to your parents that we can prevent if we work together to be very...
What the fuck? Bruh. That's crazy, bruh. That's crazy, bruh. Got any more of those... Got any more of those bra tips?
Serious about it. So one of the beautiful parts about imaging, on my podcast, we had Julius Randle recently, 3-time NBA All-Star. He's depressed, smoking way too much pot, about to get divorced. And he saw a scan, and he's like, oh no, I don't like that.
He was shooting the monster, he just hit me.
Smoking pot. And a year later, his life's completely different, because
have fun, good luck.
The images created an idea in his head that if he didn't do the right thing...
Sometimes I wonder, and listen, this is a thing that you have to remember, okay? And sometimes it can be hard with, like, certain elite educated people, like I would say doctors, like really good lawyers, these can be like elite educated people. I feel like sometimes they can have the same kind of like cognitive pitfalls that ordinary human beings do. And this is just like a vibe that I get, especially with that COVID Front Care Alliance and a lot of stuff, is that sometimes somebody can fall into the trap of like, I tried this thing with a patient one time and it was actually be outside the norm successful. And I really want to recreate this with every single patient. Maybe a doctor tried some off-label prescription once and it had some success, or they tried some, something orthogonal to, or something just way outside of the norm, and it actually worked, or it seemed to work, or it might have worked on this one exceptional case. And they want to hold on to that, and they're like, I got a new thing. I just want to like push this thing because I think it's like the secret, and it's very hard, especially once you're decades into your quackery. It's very hard to separate yourself from that thing. And sometimes I feel like when I listen to this guy, like I kind of believe him. I bet he had some patient and he did some imaging, and for whatever fucking reason, that patient was like, holy shit. Like, maybe for that one patient, when you show me that image of my brain, that was enough to change my whole fucking life. And that like impression stuck with him for so long. And I bet he actually found some other patients that it worked on, but on the aggregate, it doesn't. It's a waste of time. It's a waste of money, whatever. That's why there's no research backing it up. But it's just impossible for him to let go of how strong the initial impression was, combined with the now decades of unfortunate quackery. And I'm sure he gets a few good hits of like, oh, it worked with this guy every now and then to kind of keep the dream alive.
It was going to get worse, and he would be worse. And if he did the right thing, it could be better. One of the reasons I fell in love with imaging. It's creating the hope, and hope is tomorrow can be better and I have a role in it. It's creating that sense of agency in your patients. And if they don't ever get a scan, you could show them the images. If we don't do the right thing, your brain is headed this way. But if you do the right things, it can be better, which is why my first big book, Change Your Brain, Change Your Life, I think worked, because it was a book of strategies and hope.
Yeah, because using that motivational tool as a behavior modification tool could be quite valuable. Like, I actually am not against finding unique ways of trying to motivate my patients, because ultimately, if I had to say my biggest struggle outside of our healthcare system is finding motivation in my patients who are perhaps depressed or maybe don't even have a formal diagnosis, but have issues with life that are ongoing, that aren't easily resolvable, custody battles, divorces, etc. So my only concern with using the imaging as the compliance benefit is that if you were just using it in that way, I see the benefit. But then when you're criticizing the rest of the psychiatric community, it's almost impacting our ability to practice medicine because we're not doing the imaging.
Yep.
Do you see what I'm saying with that?
Yeah, but I can't not say what I believe the truth is.
But you believe the truth is everybody should do it, but you do it without evidence. We're looping so hard. We've looped really for 20 minutes. He is right that we're looping, but it's because Dr. Mike is trying to push him for any amount of evidence whatsoever, yeah.
Because then the field will never change.
Well, why
and
can't
if
you
the
just say
field
the
never
tool
changes,
is beneficial?
I'm sorry?
Why can't you just say, this is beneficial, this is how I motivate
But so like he can't because he doesn't have the studies, but he's going to loop again on this.
my patients? Well, when you say we're flying blind, you're creating this distinction for
Yes.
patients that are saying, we don't see Dr. Amen and we see Dr. Mike. We're going to get subpar blind care. Why would we ever do that?
Correct.
Why would anyone want to go see a doctor that's flying blind?
It's a good question.
But do you see how it sets up the dichotomy for patients where they have to make this terrible decision and they're already not in a good mental health space? So I'm curious, can we use it as a compliance booster, but not necessarily shame the rest of psychiatry? And instead,
So how do we move forward if we don't
Research.
say that
Research.
what we're doing is
Research.
flawed?
we need
We
to,
don't know if
well,
it's-
first of all, you could say what we're doing is flawed, but I think it's not fair to say you have the solution until we have
Research.
the randomized controlled data.
True.
Yeah.
You could say
And
you're
I
working
don't
towards
agree
that
because
solution.
I have outcomes on
Because I
thousands
personally,
of patients. I mean, I published
thousands.
the outcomes on
He's
the first
published.
500.
Thousands. 500. Wow.
And this is what I believe.
Wow,
that
wow,
if
it's
you
what
don't
I
look, you don't
believe.
really know. And it's
Wow.
not based on 40 cases
Yeah, I'm not
that
saying it
we've
is.
seen.
Oh.
It's based.
You keep saying these criticisms and defending them that I'm not saying. I'm not saying that you have a limited number of cases. I'm not saying anything negative about you. I'm just saying that the randomized control data that I need for universal recommendation is missing. And I feel like that's important. I mean, the critics of SPECT say, depending if you have a cup of coffee, certain parts of the brain imaging will change.
Yep.
It's the
No,
same
they're
way
very
that-
consistent over time. There's a study from UCLA, Ishmael Mena, that over 3 weeks, there's less than 3% variability. Plus, in our
Now, a really killer question is how much percentage variability do you need to diagnose something meaningfully more than you would be with just a questionnaire? I wonder if he has the answer to that. Because if you're saying that there's within 3% variability from within those 3 weeks, how much percentage variability do you need to have an assistance in your diagnosis? Does he even know the percentage? Does he have an answer to that?
clinic, we do two. We do one at rest, one when you concentrate. And so we have 100,000 rest concentration scans, and your pattern is going to be your pattern unless
Dr. Mike is clearly not buying his bullshit, but he's doing the Joe Rogan approach of glazing quacks and platforming them for 2 hours. Most people have turned off at this point. No, I think this is significantly better than Joe Rogan. You can argue maybe he's being a little bit too nice, but this is significantly better.
rest concentration scans, and your pattern is going to be your pattern unless you get drunk. It does change during the time of your cycle.
Well, hold on. Now he's saying the thing that I was saying about your pattern is your pattern. So if it's not generalizable, then how do you even know if a person's pattern is deviating enough for there to be an illness?
Which is very interesting. If you never believed in PMS, the scans during different times of the cycle will convince you it can be a real thing. They're very consistent over time.
Well, given the fact that certain things interfere with them, couldn't that make it weaker? Like, for example, when I prescribe a patient to get a HIV screening test, right? I know the sensitivity and specificity is to a level that I'm comfortable giving this test to someone who has no symptoms. But in these scenarios, what is the sensitivity of a SPECT scan.
Oh, so he's asking, yeah. Like, so what percentage does it have to change? Because it's 3% variability. So what are you looking for? What level of change are you even looking for?
On the same person, weeks apart, across a diverse group of people. And does it hold up? We don't know that yet.
Well, Mena said it was less than 3%.
Well, in that study, but I'm saying the randomized controlled data is missing to be able to diversify it. Again, I'm not talking about the initial research. I think the research you're doing is so important because you need foundational research. The first doctor that said wash your hands in between the morgue and delivering patients was viewed as someone who's making stuff up and sees something on their
Yeah, he
hands.
died in poverty.
In an insane asylum or something.
Right.
So Ignace Semmelweis. But we need to be able to test whether or not these things are valuable. And I don't understand why you're not leading the charge for that as the number one proponent.
I've published more research than almost anybody else.
But there's a
But he's
difference
just
between
saying
published
random
outcomes.
shit again.
Outcomes, how it changes clinical practice. I published on
Rip.
ADD multiple times. We have a new study coming out on bipolar disorder. We published on traumatic brain injury. I published review papers. There's a lot of published research on it. We haven't done your study.
But you keep saying it's my study.
Or the one
from
that
the
you
hierarchy of
keep
evidence.
talking about over and over again in the last hour or so.
Well, if you're trying to find out
But we've
something,
published a lot. I mean, it's very important for people to understand. In my book, The End of Mental Illness, there are 1,084 references. Because if I'm going to like make this big idea, paradigm shift, stop calling
Another red flag. David Irving did this. Norman Finkelstein did this, right? Anytime somebody brags about the number of citations, that's always a huge red flag that it's a bullshit quacks, faith healer or whatever bullshit, bad medical, bad scientific establishment. This whole like, I've got 5,000 fucking references. Who the fuck cares, bro? I don't know. That doesn't say fuck all about anything.
it mental illness. Start calling these things what they really are. They're brain health issues. That I have to be able to back that up and talk about a lot of the research on SPECT for a wide variety.
We're back to the general
of
bullshit.
conditions. But even though I can tell you the pattern for OCD, I can tell you the pattern for autism, it doesn't say what your brain who has OCD looks like. And if you don't, because if all the patterns were 80% sensitive and specific, and we have ADHD data that's way higher than that, but not everybody has that pattern. That's why you look, not because SPECT can say, oh, you have this or that diagnosis. You and I can say you have this or that diagnosis. What you and I can never be able to do, is to go, this is your brain pattern, and that's how I need to target the treatment to you, not your
Well, then what's the
cluster
point?
of symptoms.
Wait,
We
then
can
what's the
change
point?
threshold in imaging to make it appear different.
So,
Meaning that
what does that mean?
basically
Yes,
what
I
I'm
can
saying-
make your scan look terrible by changing the threshold.
Well, that's what I'm
But why
saying.
would I do that? I mean, I make how we
Well,
render
when we
the
make a
image.
threshold for what is prediabetes, we take a diverse set of people that is generalizable to the individual, and because we have this randomized controlled data, validated data, we can then say above 5.6 you're entering prediabetes, above 6.5 you're getting diabetes. But with these thresholds, do we have validated thresholds to say this is where you should set your imaging parameters? We do.
Yeah,
And what-
with normal, we have
Oh my God.
normal. So average is 72%. So SPECT is a study of relative blood flow. What that means is we take the coldest spot in the brain, make that 0, the hottest spot in the brain, make that 100, and we scale everything between these two poles. And the average, most parts of the brain outside the cerebellum, is 72. And so 2 standard deviations is 6, 2 standard deviations, 84, so above 84%. We think that's increased action.
Like, how the fuck do you know what the fuck a standard deviation is, but you don't know like what the importance is of a double-blind study? Like, how do you even? What would you even know this to mean, or what do you even think this means or is? Like, this is trolling.
Activity in the brain below 60%. We actually use 55 for safety. It's 2 standard deviations or more below. Those are the thresholds. That's how we set it. Again, very consistent with the data from UCLA.
I have an idea for that randomized controlled study that you mentioned that I could design.
Uh-oh.
What about taking people, randomizing them into 2 groups, scanning actually both groups with SPECT, but for one group, not using the SPECT data to guide treatment.
Yeah, that's what we talked about earlier.
So you're not treating off of that, but you're still randomized. Doctors still don't know. I mean, the patients still don't know which group they're in. And then going treatment-wise, and then seeing their outcomes from a clinical perspective, seeing how they're doing through patient surveys, and then also looking back at their SPECT, redoing their SPECT, and seeing if there's a change. Isn't that a great study that could truly perhaps prove that SPECT can be generalizable to the general public?
Yeah, I'll do that.
Yes, no, I think that's
I'll do
great
that.
idea.
I'll do
And,
that. I've never thought about that in 30 years of
And
ever.
then we'd probably need 3 or 4 independent Amen Clinic sites to do that as well.
I think it's an important question to ask. If we do that randomized controlled study that we've just talked about, and it turns out that it's not useful, would you give it up?
No.
Absolutely not.
That's the important. That's also one of the kill questions. Oh, I was so proud of myself when I discovered a long time ago, only the true fans will remember, where I'm like, okay, you should always ask people, what evidence would change your mind? What evidence would change your mind? And it was I think I was with Melina in New York City, and I think there was some guy, I don't even know how I found him. We were like IRL streaming, and some guy wanted to have a debate on 9/11. I was like, okay, I'm going to be real smart at the start of this debate. I'm going to ask the guy, what evidence would change your mind that 9/11 was a conspiracy? And the guy just flat out says, nothing will change my mind. I'm like, you're a king. You got me, bro. You fucking destroyed my hope in that question, and literally the first fucking debate that I fucking had. Thank you.
Why?
Why? because bro. So this guy is exhibiting. This is the thing I said earlier. He probably had some success with it, and he can't. He's dedicated his life to this. He can never change his mind on this. Look at how bought in he is to it. Look at how much emotional investment. Look at how much character investment. This is who he is. He's inseparable from this. Would you call this a treatment modality? This approach, this parrot, whatever the fuck this is. Like you can't separate him from it. And the fact that this could be wrong, it would be an admission of such a severe character defect. It would be, you wouldn't be able to survive it. You wouldn't be able to survive this.
Would you give it up?
Absolutely not.
Why?
Because how am I going to know if your symptoms are a result of your brain working too hard or not hard enough, if it's toxic or...
By doing whatever every other person in the field does that you weren't able to beat using a RCT? Like maybe what you would just do what the standard of care demands, maybe, possibly, maybe?
Dramatic. So you're just asking me to give up, 35 years of experience.
Oh, see, he's saying it without realizing he's saying it, right? My whole life? You want me to give up? Do you know how many years? Right? He's saying it without saying it. I don't even know if he realizes he's saying it. Like, he's bought in, bro. There's no shot. He's never changing his mind on this. Also, by the way, like, this would be the type of thing, not to be too... No, I will be mean. I'm sorry. If you hear, like, a doctor, like a medical professional say this would be immediately disqualifying of this person ever practicing medicine. This is the worst type of... He's killing people or hurting people, right? This is the worst type of thing that you could do, is say, I will ignore all evidence-based treatment. I will continue to accept patients doing what I personally feel is right. This is like, now you're... I don't know if I would necessarily say medical malpractice, but like you've risen to a level of you're harming people.
Showing how imaging changes what I do or guides what I do based on a study of 50 people.
Well,
now, I suspect the study will be...
People? Why'd you underpower my study so quickly?
Well, there's 300 people, right? I'm not
10,
giving up imaging because if you don't look, you don't know. I mean, they're...
Just repeats it. This is dogma. This ideology.
It makes... I mean, there are just so many advantages to imaging that,
But he can't prove any of them.
50 studies done like that.
Probably.
40 of them would come out positive, and maybe 10 wouldn't. Why? You've been around research long enough.
40 and 10? Why? What does P equal 95 mean again? Why? Or why? What do you mean? Why 40 and 10? Why?
To go, whatever the person thinks is going to happen, they'll set it up to make it happen.
Oh! Now, if I was Dr. Mike, well, first of all, we wouldn't have made it this far. He would have walked. I'd be like, oh, I wish you would have just told me that in the beginning, bro, so we don't have to fucking waste time on this 2-hour podcast. So you don't trust any scientific research because all of it is fucking biased, right? You just admitted that if you set up a study, you'll always look for the outcome that you want, but you also admitted earlier that you have highly motivated patients, and you admitted earlier that you wouldn't change your mind if anybody did a contrary study. You are the thing that you're complaining about. You literally are the thing that you're bitching about.
That maybe you have way more confidence in imaging in research than I do. But one statistician told me that 16 out of 17 statistics lie, depending on what people do.
What is a statistician told you? Did you know that 16 out of 17 statistics? What the fuck?
Thing. You saw Dr. McCary just come out recently with the hormone study, and he goes, when you actually read the study, they made that huge recommendation that kept HRT from women for 20 years, that it was actually based on flawed data. Well, so I'm not giving up.
How could you know the study is based on flawed data just from reading the study? Sounds like what happened was somebody else did research afterwards, either with the same data set or a different data set, and they got access to theirs when they couldn't validate or verify the claims, and then more research showed that this thing didn't work. He should ask him this. For the people that weren't recommending HRT, if they would say, no amount of research will change my mind on this, would you recommend that doctor to anybody? Or would you say you should probably follow the evidence? Maybe. Maybe?
The idea that imaging is useful. Can we use it better? Absolutely. And
The data from WHI is not, nor was ever proven to be flawed. The mainstream press made errant conclusions based on incorrect interpretations of the data. Ooh, well.
imaging is useful. Can we use it better? Absolutely. And we're using AI tools in studying all of our patients' data because they allow us to study
Oh, now we've got AI.
anonymized data. So in my mind, no, I wouldn't give it up.
Okay.
But there's ways to use it better. I'm certain.
You said like 16 out of 17 research articles are flawed. Does that apply to your research?
No, 16 out of 17 statistics lie.
What does that even mean? How does a statistic lie? Like the data collection was flawed or wrong, or like somebody's using a statistic in the incorrect way, or a like what does that even mean? He should just ask him, what does that mean?
So
Is that true about your research as well?
No.
Oh, he did it! He did it! Oh, he did it! I didn't think he would. He did do it. Why not though? Oh, so your research is correct, but no, like do these people? I keep saying, do these people not realize? Do these people not realize? They probably do, but they don't care because it works for them as well, right? Like, there's a reason why. Does a quack realize he's a quack? Maybe he does, but I mean, so it works for him. He's making a fuck ton of money off it, I guess, right? He had Kim Kardashian. So of course he's going to keep doing whatever fucking bullshit this is. Why not?
Why?
Because we want it to be reproducible.
But you have no RCT. Who's reproduced? How many people have reproduced it successfully in any meaningful way?
But the rest of the scientific community doesn't? I'm just asking why your assumption is that this randomized controlled study would be flawed, but yours aren't.
You said I didn't have any randomized controlled trials.
I didn't say your randomized controlled trial. I said your trials.
Oh, got him.
I just don't know why there's such a negative push to the scientific field. Like we're now discounting data because you're saying data is always flawed.
Drinking water bottle
So
strategies.
you don't believe that? Really? I mean, after all the time you've been a doctor.
Well, what's the
when
question?
You read
Specific
the
question.
studies.
Please
Let's just take the
ask
one
me a
Dr. McCary.
After all this time you've been a doctor, where do you think all the advancements in medicine have come from? Of everything, of anything. You don't think, do you think the whole field? I was waiting to hear the one meme, because I've heard some functional medicine people push this. I was waiting for the one meme of, because Jordan Peterson was pushing this lie on Joe Rogan for a while. Did you know that of all the medical interventions we've ever had, that if we just didn't have the entire field of medicine and no doctors, there would probably be less deaths? That overall they've created more death than they've saved us from or whatever? Like that, Jordan Peterson. I was waiting for him to drop that claim, but we didn't get there. Or maybe he doesn't believe that. But.
Who's the commissioner of the FDA,
Women's Health Initiative. Let's do
cited
it.
that when he actually went and looked at the data,
Okay.
it actually said the opposite of what the press release came out and said, which
The press
then
release.
hurt millions of women.
The medications that were used in that trial were appropriate for what that trial was trying to achieve, and what we were trying to extrapolate for it was not what the study was trying to achieve. In addition, the way that the study patient selected, which carries a tremendous impact on the study.
And this guy
they
doesn't
tried to
know
pick
anything
people
about the
without
study, but Mike does.
Menopausal symptoms, hot flashes, all of these things, because they were worried that if people saw their hot flashes improve, they would know, and it would no longer be a blinded study. So there are criticisms of the research, and there's always criticisms of the research.
Always.
But my concern
Always.
is that when you're ready to
But
write
not
off
mine.
the research that disagrees with you,
But
you're
accept the
part of the problem
research.
that you just said. That
True.
if
Oh, he did it. He got
you're
it.
just
True.
seeking to
You are
agree
the
with yourself
problem. He
how
got
the
it.
scientific
Yes.
community says that they,
He got
you just
him.
said they do that. They try and get research that agrees with that.
Fuck this guy.
Don't you want to try and disprove?
Fuck Mike.
Your
Get
method
out of here.
in order to prove how strong it is?
No. Fuck you.
So at this point in my career,
I
no.
know. I've proved it. At this point in my career, you think I still need research? I'm an old doctor who's been doing the same shit for fucking 12,000 fucking years. You think I need a fucking study to tell me how to treat my goddamn patients, motherfucker?
that if I looked at your scan, I feel really confident that it tells me how healthy your brain is, if it's overactive, if it's underactive, compared to not just our normal group.
Now
but
back to
our
the general statements,
hundreds of
meaningless
thousands
general
of
statements.
scans. And for you to just sit here,
I think this is like if it was like a police interrogation, there's like the soothing behaviors or whatever where the person wants to, fuck, I wish I could remember. It's been so long since I watched any of these cop interrogation videos, but this is like the soothing behavior where the guy's like clearly pressed and he needs to like a little bit of a break. And it's like, this is the equivalent, like going back to being allowed to just kind of like rattle off these very general, inoffensive statements that aren't actually saying anything controversial or making any strong claims. It's so funny to see people retreat to these over and over again. Yeah.
and go, but don't you want to prove yourself wrong? It's like, no.
That's the scientific method. When you fail to prove yourself wrong, that strengthens your
early
argument.
on.
But we're pretty early
Is
on.
this
We don't have a
helpful or
randomized
not
controlled
helpful?
study.
Yeah, no, I
What
find
if
it
you-
incredibly helpful.
What if you
but
scan my
I'm just
brain?
like, what's? I'm just asking myself, what's the point?
Well,
right? It just seems like we're arguing to argue as opposed to learn anything new.
If you scan my brain and it shows low brain activity, perhaps holes, sleepy frontal lobe. But I'm crushing it.
Yeah.
I love life. I'm happy.
What does that mean?
Excelling at sports. Podcast is going well. What does that mean?
It's not possible. That's
It
impossible.
means you have low frontal lobe activity and you're compensating for it and you're not suffering. And so
Oh, so you're saying that, by the way, it's so funny. What he's saying right now is one of the best reasons why doctors don't order a ton of unnecessary bullshit ass imaging if you're not exhibiting symptoms of something. Is because you might get an image and then a fucking retard like this might tell you, I know that you feel great and everything, but trust me, bro, you're actually super unhealthy. Let me prescribe or recommend all this extra bullshit that you probably don't even really fucking need because you feel fine and everything is great, right? Obviously, assuming we're not talking about like hidden heart conditions or something that's like obviously wrong, right? But like especially for mental stuff, men's clinics are notorious for this. If you go to if 1,000 people from chat that were men went to a male health clinic and got tested for low T, 1,200 of you would come back with prescriptions for TRT. Every single one, regardless of whether you have any symptoms or not, they will always test. It's a male fucking health clinic. They'll always test you for your testosterone, estrogen, whatever the fuck else. They'll always test you for this, right? But like when a layman gets a test and the doctor's like, oh, well, this is low. You can do blah, blah, blah. And it's like, well, fuck, bro, you're fucking these people up.
Alzheimer's disease actually starts in the brain 20 years before you have any symptoms. Frontal temporal lobe dementia starts in the brain way before you have symptoms.
This is true, right? The accumulation of the proteins that clog your shit up and fuck your shit up. Like this will start to happen, or the conditions, I think, maybe before that will start to happen before you're exhibiting symptoms for sure. But like, are you telling me that you have a reliable way to do an early detection of Alzheimer's disease? You have a reliable way to detect that and that's not published? You don't think Alzheimer's researchers wouldn't want to know that? Nobody know this. You're sitting on this one top secret technique and nobody's even thought to investigate it a bit? Really?
What it means, in my mind, based on my experience, is your brain's vulnerable, and it's probably not good for you. So you may be crushing it, but are you going to be crushing it 20 years from now? Or would it be better for you
to just have all the unnecessary testing?
To get it as healthy as it could be so you could continue to crush it and you end up not being a burden to your children?
Wow.
That's a really good question. And I think the way we figure that out is by doing the research to figure out if that intervention will get me there.
So I think we should look at your brain. I have a clinic here in New York. And the radiation is about the same as a head CT, ordered millions of times every year in the United States.
There was a recent report that CTs are raising our risk of cancer by double digits, so got to be careful about that. But go ahead, sorry.
He's so
ordered
mad.
Millions of times every year in the United States.
So the fuck what? It's a risk assessment. SSRIs are prescribed millions of times a year probably in the United States, but you don't like those? What a stupid fucking statement. Well, lots of people get CTs. Yeah, and I'm sure lots of people get fucking chemotherapy. It doesn't mean you give it to fucking everybody just because they have a lump in their throat or whatever.
I think it would be interesting. And then
Oh my God.
you could decide if it was valuable for you.
Yeah, my hesitation is, so why I tell patients who, residents rather, that want to reflexively check thyroid levels in my patients that are not having symptoms, like part of their screening, basically. A healthy person comes in and my resident automatically checks off checking thyroid. And I said, well, why? They said, well, I want to check and make sure it's optimized. So my question to them
What
is,
does that even mean?
let's say a patient comes in and their T4 is marginally low. Are you going to treat that patient who's comfortable and then give them thyroid hormone, leading them to have palpitations and discomfort? So like every time I'm ordering a test, I'm trying to think, how is this
No,
gonna
I'd give
change
them supplements
my
that do
practice of
nothing.
care?
I would just give them supplements
And
to do fuck all.
If you're saying that if I have these findings on the SPECT scan and I'm feeling great now, there's a chance I won't feel great later, I would want to know how sure of that you are based on randomized validated data. I think that's pretty reasonable to ask. No?
Nah.
I think it's also reasonable to ask, is what's your experience? Is it as healthy as it could be? And I actually disagree with you. I think people should know their important numbers every year. Like
Absolute
you should know
bullshit.
your BMI.
No.
You should know what your thyroid is doing. You should know
should.
your testosterone levels.
But there's such natural fluctuations of these numbers
Yep.
that are outside of your control that will lead you to premature, perhaps unnecessary treatment so many times. So many times.
So if
He
you're
doesn't believe in
hanging
that.
with a testosterone level of 250, which is not uncommon today,
Okay.
you think,
What time of day did you test them?
probably morning.
Because a
Personal
lot
text. That's basically my T level. Hell yeah.
of these clinics that don't do it in the morning in order to prescribe testosterone for their patients.
Which is bad because,
Very bad.
you know, too high, your libido goes up and your empathy goes down and you get bored.
Imagine if I took the advice from my mental health, my male health clinic, and I fucking got on testosterone. I would be a serial fucking. Just kidding. Video games.
First.
Well, I think about also the medical problems that come along with that.
It's like, so I'm just, I often say, how do you know unless you look?
Well, thank you so much for your time. Thank you for your work. Everyone can check out the book.
Damn.
Pre-orders until
Oh, he
December
didn't get to go over his book as much as he wanted to. Oh,
Congratulations
no.
on another. I know this is going to be a New York Times bestseller. So wishing you the best of luck for that.
Aw.
Thank you. Click here to see a list of 10 surprising causes of headaches. Your pillow could be.
Jesus Christ. That was a brutal one. Well. What are you going to do? Dr. Mike's an asshole. I feel like every book these days is a New York Times bestseller. So I think one thing that people do that I've heard about, I don't know how true this is, but like to be a New York Times bestseller, you don't have to sell that many copies. And and I don't even think it's like a secret, like a super scam or whatever. But like, let's say that I know I'm going to be doing some type of event or whatever, like a DGG event, and then I write a book. What I could do is I could just advance order 5,000 copies of that book to give them away at events, or maybe even to sell them. And with that advance order, it's enough to like put me on the fucking New York Times bestseller list. You kind of like automatically do it as long as you have the capital to hold books for a while you sell them off, hopefully.